Good morning. Good morning. Happy New Year. Nice to see folks back. And this meeting will now come to order of the Healthcare Affordability Advisory Committee. Please note that this meeting is being recorded, and we will start, as we always do, with a roll call.
Good morning. Joan Allen.
Present.
Barry Arbuckle.
Present.
Katie Bassler.
Present.
Stephanie Klein. Carmen Comsty.
Present.
Adam Daughtery.
Present.
Hector Flores.
Here.
Stacy Haratas. Iftikhar Hussain. David Joyner.
Present.
Travis Lakey.
Present.
Tham Ma. Amanda McAllister Wallner. Carolyn Nava. Mike O'Day. Janice O'Malley.
Present.
Mario Riazza. Simona Reddy.
Present.
Christina Rodriguez.
Present.
Thank you. Karen Savage Sangwan.
Present.
Andrew C.
Present.
Manan Shah. Stephen Shortell. Sarah Srokin. Ken Stewart.
Present.
Suzanne Usage.
Present.
Michael Weiss.
Present.
Wonderful. Thank you.
Thank you very much. So with that, we have a record of who is in attendance. And I'd like to note that joining us today is also our attending board member, Ian Lewis. So as our board members always do, we think the staff does a great job capturing the important points that you make, which is very crucial to us to share with the board. And then we appreciate that board member Lewis adds on to that to make sure that your thoughts are adequately conveyed. Happy 2026 to all. Appreciate all of those of you who are here in person and made the trek through the fog to be with us. Also appreciate those folks who are online. I missed the last advisory committee meeting, so a special welcome to those folks who are joining the advisory committee or joined us last meeting, and appreciate those of you who are sticking with us for another term as we continue the work and start the fourth year of the Office of Healthcare Affordability and our work together with the board and the advisory committee. So we'll pull up the slide with today's agenda. After executive updates, we'll have a brief update on the behavioral health out-of-pocket spending, which is an important topic we've been talking about since the beginning of the office's work. Then we'll be introducing the Data Submission Guide 3.0 regulations, including an update on the behavioral health definition and a summary of feedback received from the board in December on this topic. Then we'll be hearing from OCA's compliance branch to receive an update on the cost and market impact review program. We are estimating that we'll break for lunch about 12:45, and when we return, we'll have a discussion on OCA's spending target enforcement, including waiver of enforcement, technical assistance, public testimony, and performance improvement plans. And then last, but very important to us, we'll close out today's meeting with an introduction to the HCI Health of Primary Care in California Snapshot, which we will be launching later this year, including some OCA data. Moving to executive updates, my main update today is about California's Rural Health Transformation Project. So I think Hova Khosrovian was here at your fall meeting to talk about the proposal that HCI put together on behalf of California, and we knew that we would hear from CMS by December 31st. So on December 29th, California got our notice of award from CMS. that California was provisionally being awarded $233.6 million for the first federal fiscal year 2026, through the Federal Rural Health Transformation Program to support rural and frontier communities across the state, which is very important to us. We think it's always important to acknowledge that it's not going to make up for the cuts that are coming to Medicaid and Covered California and SNAP and other pieces through HR 1, and these are really important investments that we're committed to making as meaningful a difference as we can. The funding amount that California received is the third amount received from CMS. Alaska and Texas were the top two scorers and therefore got the highest amount of funds. But if you look at California on a per capita basis, we're one of the lowest because of the way the funding was allocated. Every state that had an approved application got the same amount, with half of the money, and the other half was distributed based on scores. So these funds will be held for California while HCI updates the budget and provides further details. So our original budget was for $200 million a year, as we were instructed to do. Now that the award amount is larger, we have to submit a revised budget with the new amount to CMS by the end of January, and they then have 45 days to respond and approve the budget, and they are giving themselves very wide latitude also to disallow certain costs. The initial budget period for this first year of funding is through the federal fiscal year in October, and then CMS will provide funds for subsequent years at the completion of each budget period. So again, I think we've outlined the basic components of California's Rural Health Transformation Program, which is first and foremost a transformative care model to help support existing hub and spoke models between larger hospitals with more specialty care, connecting with rural hospitals to provide e-consult and other supportive services, also with clinics. That includes some stability or transformation payments that we've proposed, important workforce components. We've heard universally from rural hospitals and clinics about the need to expand and support existing rural workforces, and then technology and tools to help modernize electronic health records, allow for data exchange and the like. So those are the three components. Still working with CMS on the budget. Really appreciate the engagement we've had from stakeholders as we continue to move forward. So with that, a reminder to speak into your mic. Your mic is your friend. And with that, I'm pleased to turn it over to Deputy Director Vishal Pagani.
Thank you, Director. First, I want to remind the Advisory Committee and the public that on January 5th and running through March 31st, 2026, OCA has begun accepting submissions of interest forms for individuals who want to serve on the Advisory Committee. The submission portal will close at the end of March, and in April, OCA staff will begin evaluating the various submissions received. By June, OCA will meet with two members of our subcommittee, which are Sandra Hernandez and Ian Lewis, to develop a recommended slate, and then that slate will be presented to the board in July. We want to note that this selection timeline is flexible, and a recommended slate could be presented to the board as early as May. This slide just shows the composition of the existing advisory committee and vacant a vacant position listed here for payers. So this recommendation will be presented for the payer vacancy later this month at the January 28th board meeting. So including the payer vacancy, there are 16 seats with terms scheduled to end on June 30th. All current advisory committee members will have the opportunity to resubmit if they choose, and the selected members will serve a 2-year term from July 1st, 2026 through June 30th, 2028. And as you all know, the advisory committee meets quarterly or 4 times a year and provides an input on a range of healthcare topics of interest to the board. Further information and a link to apply is now on the OCA website. So I'll take us now to a summary of the Monterey County Hospital Market Competition Study that was published on November 13th. And we've covered this topic before with the advisory committee. There have been concerns over hospital prices in Monterey County that have been building for years. In August, OCA held a public meeting specific to these concerns. On October 14th of 2024, Director Landsberg ordered OCA to conduct an investigative study of hospital market competition in the county. We retained Arnold Analytics as our economic expert to assist in producing the report. The report investigates potential reasons why hospital prices in the county are among the highest in California and the nation, looking at data relevant to 3 Monterey County hospitals, including Community Hospital of the Monterey Peninsula, or CHOMP, Natividad Medical Center, and Salinas Valley Medical Center. Next slide. So in the report, new hospital price analyses show Monterey County to have the highest inpatient and 4th highest outpatient prices among California counties. Analyses in the report show there's no evidence that higher operating costs, wages, or quality explain the higher prices. High percentages of Medicare and Medi-Cal patients and low margins on physicians and clinics may explain a small portion of the high hospital prices. Evidence suggests a lack of competition as the reason for high prices. The profound lack of competition means the market forces alone are unlikely to reduce hospital prices, and the state may need to consider additional policy options that directly restrict the pricing power of the hospitals in the county. These may include setting hospital price caps or instituting hospital global budgets. So next is our projected timeline for revising CMIR regulations as a result of Assembly Bill 1415, which was signed by the governor on October 11th. AB 1415 amends the OCA statute. The changes that took effect on January 1st of this year expand the requirements for transaction notices and those who must file such notices to include private equity groups, hedge funds, and management services organizations. So we've begun engaging with stakeholders since last November, and we're continuing to refine text for regulatory updates, which we plan to bring to this advisory committee in April. We'll also have a public comment period, and then we'll begin a formal emergency rulemaking process with the Office of Administrative Law. And then I'll go over a few articles. So the first one is a research article. It's an October 2025 study from the California Healthcare Foundation. It highlights that around 25% or a quarter of every dollar spent in the system does not contribute towards better care or patient health. This money instead goes towards administrative waste, unfair pricing due to a lack of market competition, services for serious medical conditions that could have been prevented if caught earlier through investing in basic primary care. The study estimates that this equated to around $75 billion in wasted healthcare spending in 2020. They go on to note that in addition to setting cost targets, which OCA has done, some other solutions can include reducing the costly back and forth for prior authorization, implementing a statewide data exchange, which California is implementing, addressing monopolistic pricing, including increased oversight in California where there are few hospitals, health systems, or insurers. And then as mentioned in the prior slide, AB 1415's passage increases our cost and market impact review program's ability to monitor a greater variety of transactions that the office could not previously assess. And then lastly, they mention increasing investment in primary care and the state's infrastructure for such care. Next slide. So this is a health affairs piece. It's from Baylet Health, and it looks at 2023 spending data from 5 states with healthcare cost targets showing a 40% increase in non-claims payments, which was largely driven by MA or Medicare Advantage non-claim spending. So while we generally kind of look at increases in non-claims payments as a positive sign suggesting a shift away from fee-for-service towards APMs or alternative payment models, a closer examination reveals insurer-provider vertical integration, potentially weakening the effectiveness of the medical loss ratio requirements for insurers. So as a reminder, the medical loss ratio established in the Affordable Care Act generally requires either 80% or 85% of an insurer's premiums to go towards medical care and quality improvement activities, as opposed to administration, marketing, or profit. In addition, a company that is vertically integrated, or a company that's vertically integrated means that it owns or controls more than one entity in the supply chain. For insurers, this would mean acquiring physician practices, outpatient clinics, and sometimes entire health systems. So as a result of this vertical integration, payments to affiliated providers count as medical spending when calculating the insurer's medical loss ratio. There is not a medical loss ratio requirement for providers, so there's an incentive here for the insurer to direct spending to these affiliated provider entities who may charge inflated prices and allow the insurer to increase its MLR without delivering more care or improving quality. So they give an example here, which is interesting. So it shows company X owning health insurer A and clinic Y. Another health insurer B is not owned by company X. When a patient covered by health insurer B receives a service at clinic Y, insurer B pays the clinic $300, but another patient covered instead by health insurer A receives the same service at clinic Y, and then health insurer A pays the clinic a lot more, $500. So the $500 is counted as medical spending in the health insurer A's medical loss ratio, even though the additional $200 didn't buy any more care. It just represents internal profit for the vertically integrated entity. This dynamic reveals a limitation of the MLR rules. When the insurer is also the provider, there's less transparency into how healthcare dollars are actually allocated, and there's incentives to artificially inflate prices. So there's currently not a standardized way to assess the extent to which insurers that own or are otherwise affiliated with clinics and health systems are taking advantage of this loophole. However, there's a growing trend towards insurer-provider vertical integration, and the potential cost implications could be significant. There's some policy recommendations in the piece, which include states requiring insurers to provide more detailed information on transactions between related parties, including non-claims payments to affiliated providers and the pricing methodology used to develop those APMs. Overall, they're pointing out to some of the limitations about MLR, and it'll be important to track this issue as we look at cost containment efforts. And then moving on to another article. So this one's about the hospital payment cap that was implemented in Oregon. They implemented one in October 2019 that prohibits carriers from paying in-network hospitals more than 200% of Medicare and out-of-network hospitals more than 185% of Medicare. So a previous evaluation found that Oregon's payment cap was associated with a 25% reduction in outpatient facility prices and a 3% reduction in inpatient facility prices. generating more than 100 million in savings for the state employee plan during the first 2 years of the policy. According to the author's calculations, these savings translated into an average reduction of revenue of approximately 2 million per hospital per year, or less than 1% of average hospital revenue. The focus of this hospital is taking a look at broader impacts of the payment care on delivery, employment, and the patient experience. If reductions in hospital revenue led to staffing cuts or compromised patient care, this could have significant negative consequences, but if these outcomes remain unaffected, the revenue reductions may simply result in reduced income for activities that would have strengthened the hospital's market power or financial reserves. So they do include the findings here, which are no detectable changes in net patient revenues, patient care expenses, or operating expenses compared to a synthetic group of non-organ hospitals. No evidence of disruptions to hospital operations, no observed decline in the patient experience of care. In some cases, there was modest improvement. However, they do note that these findings may not be generalizable to the broader commercial market. It appears that Oregon's hospitals were able to absorb the losses from a payment cap when applied to a subset of patients without widespread disruption. But hospitals could respond differently if the caps were applied more broadly. The authors conclude their findings that their findings have implications for state reform efforts, and noting that state employee plans can potentially adopt similar payment caps that Oregon has instituted. So I'll go over just two more pieces. So this one is about a market consolidation piece in the New England Journal of Medicine. It's an opinion piece. The author is looking at the growing share of investor-backed corporations, regional health systems, and private equity firms controlling hospitals, nursing homes, and physician practices. They refer to this as a corporatization of healthcare, which is not only consolidation, but financial strategies that prioritize the interests of stakeholders over patients, healthcare workers, and local communities. They give it, there's more detail about these three sectors here. They note the hospital sector is highly concentrated. They also go into skilled nursing homes and physician employment, shown here. And then taking us to the next slide. So they argue that existing antitrust tools to address anti-competitive behavior are rarely effective against these frequent and sophisticated financial strategies deployed by corporate entities. Taking hospitals, for example, private equity firms drive profitability not by raising prices, but by entering into real estate investment, real estate leaseback agreements. This is when a hospital sells its land to a real estate investment trust for upfront capital, which typically benefits its financial backer, but the hospital is then responsible for paying rent to the trust. This process is rarely captured by merger reviews and competition analysis. They provide a similar example unfolding in physician practices, whereby private equity firms, health insurers, and other corporate actors are increasingly using MSOs to aggregate practices across markets. And then the MSO is able to negotiate payer contracts without formally owning or controlling the clinical entity. So in this instance, MSOs can replicate many of the effects of consolidation while avoiding regulatory scrutiny. They note that despite Federal Trade Commission and Department of Justice merger guidelines that highlight concerns about serial acquisitions and competitive risks posed by vertical integration and cross-market mergers, antitrust enforcement is reactive. It's really transaction specific, and it's often lagging behind this process that the author refers to as corporatization. So they note that antitrust is still important, but it has its limitations, and policymakers must recognize additional complementary strategies that center health, not shareholder value. These include the policies listed here, such as ownership transparency. And then I'll provide an update on OCA's data collection efforts. This slide shows at the November Healthcare Affordability Board meeting, we presented board members with an updated draft motion for the data submission penalty structure. The presentation included prior feedback that was summarized in terms of feedback from the board, feedback from the September advisory committee meeting, and then a summary of verbal and written public comment received by OCA. So the motion was approved, and I'll go into what the scope and range of penalties are. So this slide shows how we've structured this in terms of 3 levels. Level 1, we assess an administrative penalty of $10,000 for data not submitted by September 1st of the submission year or an agreed upon extension date. Level 2 would be a $50,000 penalty assessed for data not submitted by November 1st. And then level 3 is an additional administrative penalty up to a base amount of $5 per member if data is not submitted by December 1st, and then up to $10 per member if data is not submitted by December 31st. The per member base penalty amounts will double each consecutive year that the office assesses an entity a level 3 administrative penalty. And then we note that these penalties do not limit OCA's ability to pursue other legal remedies. And I'll cover the last update on measuring OCA's methodology for measuring inpatient and outpatient hospital spending. So we've touched on this topic before with the advisory committee. We just covered it at the December board meeting as well. And just to recap, the hospital financial data, or sometimes it's referred to as the hospital financial disclosure report data. It provides net patient revenue for both inpatient and outpatient care. If we move to the furthest column on the right here, the hospital financial data also provides counts of inpatient discharges and outpatient visits. So those are our volume numbers. And so we have the revenue numbers on the left, and then we have the volume numbers on the right, which are the discharges and outpatient visits. And then for measuring inpatient spending, we want to apply something called a case mix index. And that's from a different data set referred to as a patient discharge data set. And that supports adjusting for inpatient intensity. For outpatient intensity, the healthcare payments database, or California's all-payer claims database, offers a sample of claims claims and encounter level data needed to calculate outpatient weights for the outpatient intensity adjustment, which we refer to as the average visit intensity. With these data sources, we have the revenue, the intensity, and the volume data needed to calculate parallel spending measures for both inpatient and outpatient services. So I'll walk through this step by step. So under step 1 of the methodology for measuring inpatient spending, we first multiply the number of inpatient discharges by the inpatient intensity adjustment, or the case mix index. The case mix index details how many resources were needed to deliver care compared to a standardized unit of service. So it's designed to count inpatient discharges in a similar way, whether a hospital is focused on less acute community care or more intensive tertiary services. So the calculation under step 1 yields case mix adjusted discharges, or CMADs. And then in step 2, we take the inpatient net patient revenue number, and then we divide it by the number of CMADs. So this gets us to our final measure, which is inpatient NPR per case mix adjusted discharge. So this better allows us to isolate average spending for inpatient hospital services while accounting for how much and which services hospitals provided. Next slide. So similar to the inpatient spending measure calculation, we would multiply the number of outpatient visits reported in the hospital financial data by an average visit intensity adjustment, which will be calculated using HPD data. This results in an outpatient intensity. This results in the gray box, which is intensity adjusted outpatient visits. And then in step 2, we take the outpatient NPR, or net patient revenue number, from the financial data, and then we divide it by the number of intensity adjusted outpatient visits. That gets us our outpatient spending measure, which is outpatient NPR per intensity adjusted outpatient visit. You know, since we're using the HPD, wanted to just briefly provide the advisory committee a walkthrough on how we're doing this. So as noted on prior slides, we calculate average visit intensity using claims and encounter data. So in the HPD, providers are identified by NPI, or National Provider Identifier. The hospital financial reports are license level annual reports, and they have a HCI facility ID and a CMS certification number, or CCN. And then we need to align HPD claims and encountered data with entities that submit in the hospital financial report. So we match the NPI to CCN at the parent level. And this slide shows kind of how this mapping works. So within HCI's hospital financial reports, you know, there's data. This slide shows an example of how the data within HCI's hospital financial reports is matched with the data found in the Medicare Provider Analysis and Review, or MedPAR database from CMS. And then we crosswalk it into the HPD via the facility's NPI for usage by our research team, and being able to make that linkage so that we're identifying unique facilities. And then in terms of counting outpatient visits in the HPD, so the hospital financial report includes the total visit counts reported by the hospitals. And then we want to make sure that we're applying the same definition in terms of how hospitals are counting outpatient visits in the financial data they submit. And so we want to have fidelity to that definition when we count those visits in the HPD. The definition is shown here. If a patient visits more than one part of a hospital, that is 2 ambulatory cost centers, that may count as 1 visit for each ambulatory cost center. Ancillary services, so these are like lab tests or other services like imaging, they may not count as additional visits during the same day as the ambulatory visit, but they may count as a separate visit if no ambulatory visit occurred that day. Next slide. So OCA will use Medicare's ambulatory payment classifications, or APCs, to estimate average visit intensity. APCs correspond to procedure codes shown in parentheses, and APC weights are publicly available on the CMS website. HPD claims are assigned an APC code and APC weight, and then those are pulled from Addendum A from the CMS APC list of weights. For each payer type, we calculate average visit intensity by dividing the sum of the APC weights by the number of visits we found in the HPD. So with this method, we're able to calculate a payer-specific average visit intensity. And then in terms of next steps, we plan to post OCA hospital facility to NPI crosswalk on our website. So this is an opportunity for hospitals to confirm the NPI maps to their California license number. So we want to make sure that we're appropriately identifying hospitals in the HPD. And then in March, we'll update the crosswalk to reflect hospital feedback and then apply the outpatient measurement methodology to 2022 and 2023 data. In April, we'll post a revised crosswalk and a facility level data set that includes measures for payer-specific inpatient and outpatient spending for calendar years or fiscal years 2022 and 2023. So this is kind of what we show at every advisory committee meeting to remind the committee and the public. So blue arrows denote areas where we're looking for input or recommendations and from the advisory committee. And then I'll turn it over to our facilitator for any questions from the committee.
Great. I think we'll go to Andrew first, and then we've got Adam, okay, Travis. Okay, thank you.
Yeah, Vishal, just a question on the hospital measurement. On outpatient, how complete is HPD? I'm just thinking about self-funded plans. And so, the HCI data is very complete on hospital financials, but just wondering when you're calculating intensity, are we really missing? I mean, you're basically making an assumption that the fully insured and self-funded plans have average intensity that's the same. I'm not sure that would be true. I don't know that we have any better source, but I guess it's a question to staff if we are complete. And then the second thing is the intent to measure hospitals inpatient, outpatient separately? We're not going to try to put them together. I'm just trying to think through incentives, right?
Oh, yeah. Right now we're looking at calculating the measures separately. So we did explore some combining of the measures. We did get feedback from a separate hospital spending measurement work group about kind of wanting to understand the outpatient measure on a standalone basis. So we at this time they're separate. In the future we may combine them, but even if we were to combine them, we'd still want to report the two measures separately. And then in terms of completeness of the HPD, it doesn't include the full universe, as you know, with the self-insured lives. And then our December board meeting presentation does have more observations about kind of the data in the HPD. So we do have less commercial claims data in terms of counting the number of visits in the HPD by applying the same rule that the hospitals apply for the financials. We did pick up more Medicare and Medi-Cal visits. And then we're essentially using the HPD as a sample to estimate average visit intensity and then applying it by payer. So while there were different sample counts in terms of size, we did still find that the measures were still correlated with each other in terms of predicting visit intensity. The individual payer level measures were, even though there was a smaller commercial sample, when we combined them all into an all-payer visit intensity, they still correlated with each other. So despite the sample size, that kind of gave us reasons to kind of move forward with using the HPD as a data source.
Okay, we've got Adam, Travis, Stephen.
Thanks, Vishal. I don't know if it was previously explained, I can't recall. The case mix index, I was hoping you could expand on the definition of that, if there's a historical definition, what you mean by amount of resources, and if that's defined anywhere, how that's
Yeah.
counted.
It's basically taking the DRGs and then applying a weight. Those are published by CMS, and then basically adding up all the DRGs and then dividing it by the number of DRGs, and then that gives you the case mix index.
Okay, Travis, Stephen, David, and Joan.
Is there any way to capture the high-cost drugs that are being given in these outpatient procedures in this methodology?
Yeah. So the APC weights include the high-cost drugs, and they include weights for those. And then there's there will be some cases where there's not an APC weight for a particular year if it's like a new drug, but there is a way to essentially calculate the weight through some of the technical documents that CMS provides. So the hospital's paid for that drug, but there may not be a weight. But then you could kind of calculate the weight because each weight, it's essentially a standard unit. Like one APC weight corresponds to a dollar amount. We're able to kind of back into the weight and then apply that to the high cost drug claims it encounters.
So at this point, are we just talking about this or everything you went over in the executive updates? Everything. Okay. Well, I wanted to thank you guys for your work on the RHTP because very well thought out. Great job getting more than you expected. Is there any thoughts or ideas on the extra 33 million? Is that going towards stability funds, or is it going to be distributed evenly, or are you that far yet?
Yeah, thanks very much for the question, Travis. So we're still evaluating where to put it and trying to figure out where it can be most meaningfully leveraged right away. So we think tech and tools is going to take a little longer. On the workforce side, our proposal is to actually do a more in-depth workforce analysis for both primary care and maternity care needs. So there'll definitely be some resources. So I think we're looking at a little bit more for workforce and some more for the transformative care model, with the big caveat that all of this has to be approved by CMS, and there's a lot of unfriendly language in the notice of award that we're sorting through.
Well, and I was very impressed how much we got with the unfriendly environment. So great job.
All right, Stephen, David, Joan, and then Hector, I see your hand raised online also. Thank you.
I would just second what Travis has said. A few comments or maybe suggestions on some of the articles you reviewed. So the CHCF study breaking out, the 25% problem. One of the things would be useful if in the future they could also look at low value care as well. It may be in the overtreatment box, and I'm not sure. We could ask them about that, but it's more different from overtreatment per se. So that's just one suggestion. There's a center at University of Michigan that Dr. Mark Fendrick heads up, and he has done a lot of work on low value care, what it is, how to calculate it. They developed a calculator for it as well. You may know that, staff may be aware of that, but that would be something to look into. And then the finding about the vertical integration and insurers and so on, it'd be interesting to look at that in terms of breaking it out by market concentration in the state. So to the extent you can do that, one would expect that loophole is going on more in the more concentrated markets than less concentrated, but that would just be some interesting information to have. And then the final comment is just about the Oregon study. And I think there's a lot of caveats there, but just to remind all of us that it's very short term and not to overinterpret that at all. You really need to look at it longer term in terms of the impact on hospital operations and so forth. So just a few thoughts.
Thank you. David?
Yeah, my question is about the hospital measurement. So you always worry with these measures that mix changes can get you into trouble as well as severity changes, severity of patients. And I'm curious on the inpatient side. Vishal, I know you mentioned you're using the DRG weights, are they severity adjusted DRG weights, and are they all payer DRG weights? Do you know?
They're the MS-DRG weights.
Okay, just a thought. There is something called APR DRGs, which APR stands for all patient refined. So they have two elements to them. One is they adjust for severity. So like all gallbladder surgeries are not the same. A gallbladder surgery on somebody who's morbidly obese and is 60 years old is not the same as somebody who's 30 years old and very fit, as an example. And then there's also the CMS weights don't generally measure pediatric or maternity very well, and so they're refined for those kinds of services. So it might be worth investigating. It's APR DRGs, all patient refined.
Are you speaking to kind of the MS-DRG weights kind of have a weight with or without complications, but then the APR goes more granular?
More granular. So
Okay.
I think there's 4 levels of severity for each DRG, and also they've beefed up the pediatric and maternity weights because the CMS weights aren't very helpful because they have so little volume.
Okay. I think, yeah, we could take that back. I suspect it might be a proprietary tool if it's like a 3M.
I think it's a 3M tool.
Okay,
Yeah, I think it's definitely it's a more accurate measure because it tries to adjust both the severity as well as the mix of services, because CMS tends to underweight maternity and pediatrics.
Okay. Yeah, there's trade-offs like at least with the MS-DRGs, anyone could look that up.
Yeah.
But then with the 3M, they won't know what specific weights were applied.
Just the MS-DRGs for something we're trying to measure a multi-billion-dollar industry, and I would say to not use a more refined strategy because of a concern about it being costly or proprietary. I would, if I were you, I would revisit that question. The other question I had on the outpatient side, I know that like some hospitals have, for example, a very, very large, busy emergency room and not much outpatient surgery, and you might have another hospital that has the reverse maybe. How are you going to get around trying to, again, compare hospitals fairly and not have, erroneous conclusions because it's more driven by the mix of the services rather than by the underlying economics for outpatient?
Yeah, I guess I'd want to understand your question a little more, like the average visit intensity, would that account for that? Or?
I don't know that it does. I don't know that a visit intensity could compare like a trauma case coming to the emergency room versus something that's urgent care eligible. I could see how that could adjust for that. If you got a trauma center, their emergency room volume would probably be more severe than somebody that isn't. So I think that makes sense to me. But I think in terms of when you look at all outpatient encounters, I think it's challenging to look at the mix between different kinds of outpatient. You have outpatient surgery, outpatient lab, you have outpatient imaging, outpatient emergency room, and they're all, the economics are all different, the cost per patient are different, and so I worry that your methodology might not capture the element of mix. It might capture severity within a category, but I'm concerned it might not capture mix.
Okay. Yeah, we'll have to think about that. I think I think on the outpatient side, there's not like a diagnosis aspect for these APC weights like there are on the inpatient DRG side. It's more about the intensity of the services.
Yeah. I mean, one suggestion, I know this is complicated, maybe you avoid lumping all outpatient services together, and just as in the same way you can compare hospitals against each other on the inpatient dollars per RVU or something like that, maybe you just have to measure it by line. So emergency room versus outpatient surgery, etc.
Okay.
I just think by combining them together, you can create a lot of erroneous conclusions which are driven by mix, not by the actual economics.
Okay.
Thank you. Joan, Hector, Barry, and Carolyn.
appreciated the update on the NPI mapping, particularly combined with the vertical integration discussion. And great to see a timeline on that for hospitals. Is there a timeline for non-hospital entities, particularly rolling individual physicians up into physician organizations?
Which timeline were you referring to?
So the sort of how you're grouping NPIs by hospital, giving the hospitals a chance for feedback on that, and then getting toward a finalizing of that list. Because the little bit of digging in I've been doing on how many NPIs a hospital has, it's going to be challenging mapping that in the HPD. I was wondering about the next step of doing that for non-hospital entities.
Okay. So this is going to be a tremendous resource for researchers to be able to have this hospital facility to NPI, even for hospitals that are requesting data. Anyone, or there's a process to become a receiver of data through the HPD. So we'd be putting out this mapping, which will be a resource so that users in the analytic environment in the HPD could be able to make those linkages. For the non-hospital entities, I think that's going to take a longer time. Like, as you know, like physician organizations aren't licensed in the state. There are other data collection efforts for THCE. We're learning more about that space, and then I think we use tax identification. We use TINs in that respect. So yeah, we're kind of starting with hospitals, but we will eventually need to be able to identify physician organizations more systematically. But yeah, I don't have a firm timeline on that.
Okay, but it's in a general pipeline.
Yeah, it's something we think about a lot. Like there's also specialty physician organizations as well, and yeah.
And then linking that in with the vertical integration conversation, is there an effort ongoing to basically define systems and be able to see that vertical integration?
So there is an existing resource that it's called the Compendium of Health Systems. I think AHRQ, the former AHRQ, put it out. So that does have some major California systems in there. And then they have a specific definition for health systems. So they're defining physician organizations in a specific way. So there are some data sets out there, and then we are exploring that, whether we could build off of existing data sources to kind of map these organizations. But that's kind of on a longer trajectory.
Okay. And then, as you know, Joan, we tried through legislation last year to include health systems as a healthcare entity because they aren't currently. So we do have this fragmented list of healthcare entities that, had we, anyway, I think it would be beneficial to add it, but we do have that limitation as well as the data limitation.
Appreciate that.
Thank you. Looking to some of our virtual attendees. Hector, go ahead.
Thank you. So I wanted to just echo what Steve Shortell mentioned about the Oregon study. It's early, and we definitely need to look at it very carefully as something we could apply. But I did want to comment on the vertical integration piece. I think transparency, will solve a lot of these headaches that we have, because gaming as a system goes on everywhere that we look, and that's certainly something that you highlighted on the vertical integration. But I do see the value of the vertical integration model because we can apply alternative payment models to it, and I personally believe if we have everybody in California in some kind of APM, and not only does it motivate and move the needle towards value and equity, but it also gives us the impetus for collecting better data. And something that we need to also be mindful of is that every community that is served, except for maybe closed systems, the network that health plans and these other organizations have often includes safety net providers that are also going to be taking care of uninsured patients. And as we all look at mitigating the impact of HR1, we need to have a new strategy across California that begins to address how we all share the care of those that either continue to be uninsured or will become uninsured because of the features of HR1. So I do see vertical integration as a great opportunity, alternative payment models for everybody as a moving the needle towards equity and collecting data, and also beginning to identify how we all share the care of people that remain uninsured. I think that's a really critical piece in all of this, and transparency should dominate everywhere. So thank you.
Thank you. We've got Barry and then Carolyn, and then we will wrap the discussion on this item. We do have a full agenda today. Barry?
A couple of items. I want to echo the congratulations on the rural health grant, particularly in this hyper-partisan environment we find ourselves in. I think it's impressive. Have we seen as an advisory committee any more detail about the 3 initiatives in terms of what sorts of grants or applications will be, what it'll be used for?
Yeah, thanks, Barry. We do have some, our application is on our website, so we're happy to link to that. And I wasn't here in October. I thought because Hovik gave an overview of the 3, so there is information on our website, and we're happy to help distribute that.
Okay, very good. I mean, by example, on workforce development, I didn't know if this would even be applicable, but with the efforts to try to reduce costs, particularly in provider sites, hospitals or physician organizations, which are predominantly the biggest expense is labor. There is a very big movement toward robotic process automation, use of AI increasingly that replace jobs. And a lot of organizations are trying to retrain, but don't know how. And so I didn't know if that would fit on workforce development or if that's completely down another path.
Yeah, thanks for flagging that, Barry. So I think for our workforce development pieces for rural health at this point, we're focusing on primary care and maternity care professions because we have a lot of other investments in behavioral health. And on the specialty side, we're mostly looking at e-consult. We do have some retention pieces. We do have some training and retraining and really looking at those workforce ladders to try to help folks with their professional development. So I think the potentials for AI, I think, are more on the tech and tools side, but we do want to try to empower existing workforces and give them new skills. One thing we were really pleased about with the Rural Health Transformation federal application was that it recognized the importance of community health workers and promotores and really helping consumers. And so I think there's a piece there, but we're certainly on the workforce side, mostly focused on the human side. And definitely, I think retraining is an important piece and, would welcome specific ideas on that.
Thank you. On the CHCF study, I pulled that up just to read it, and under the administrative waste, which obviously the article's about, they cite several things, which I think are all perfectly valid. But one of them is bureaucracy and red tape. I can't recall exactly what they referred to it as. And that caused me to go to a search engine that is an AI-driven search engine that's used in academia to search states that have the most regulations on hospitals or providers. I can tell by your smile, you know exactly who is number 1. No matter how I ask the question, in terms of day-to-day, number of regulations that must be adhered to, the costs of adhering to them, just at 30,000 feet, the sheer number of them. And I have to imagine that a number of them within our state are now archaic. In fact, I still believe in Title 22, in fact, I'll quote, that it mandates that records be either typewritten or legibly written in ink and able to be photocopied. Probably not as relevant today. So I didn't know if there was an opportunity or a task force that could go and try to clean out some of those regs because it is quite burdensome. So just probably can't be answered.
Point well taken, Barry. Someone's clapping in the room. So yes, we're at HCI within this administration very committed to good government, and it is hard sometimes when things are on the books, and the legislature is good at adding new things and not as good at taking things away. So I don't know as well the definition of administrative waste that they're including. So I'm not aware of a current initiative to try to take out things like requirements for typewritten documents, but certainly hear the very valid point.
2 other quick ones on the, I think it was really good, that piece, the Bailiff piece on the vertical integration. I haven't pulled up Bailiff's article. I will do that, but I was curious if he also looked at payers that own PBMs. PBMs are a incredible opportunity for the PBM that is a sister company, not included in the MLR calculation per se, but to charge the highest drug cost to the health plan, to increase MLR, which gives more room for G&A and profit, and it produces enormous profit over in the PBM, which then feeds the parent company. I say this because I've seen it, and I was shocked by the delta of drug costs, item for item, across the various PBMs that are out there. So I may even reach out to Mike Bailiff if he hasn't included that and suggest that he do so.
Yeah, it's a great point. I think we're very concerned about the costs that PBMs contribute to healthcare, and folks are probably aware there's some legislation that was included in the budget, some legislation signed that was authored by Senator Weiner about PBMs, and we're really excited that we will start collecting PBM data in the healthcare payments data program so that we'll be better to understand, lift the hood on those costs.
And then finally, I promise, on the Oregon study, and we've seen a number of these that use a percent of Medicare, which seems to operate on a belief that Medicare rates are logical or equitable, and they're not across institutions. And I've given examples in this room about two very comparable hospitals that have Medicare DRG base rates that aren't 10 or 20% different, they're 30 or 40 or 50% different. And I would be concerned that using a percent of Medicare, whether it's 200% or otherwise, might encourage some of what we are seeing today in California. Hospitals that have high Medicare DRG rates, let's say an academic medical center, for example, license themselves over a community hospital and applying those rates to get that ratchet up. So I think there's, the Oregon, we need to look and see. I think Dr. Shortell's comments were good. Let's give it some time to see what the impact of that exercise might have been. Thank you.
Thank you. All right, we'll go to Carolyn to wrap the discussion on this item.
Thank you for the wrap-up, Jane. I want to, first of all, acknowledge Stephen's comments about low-value medical care, because I have a brief story to share with our committee this morning that came to me personally as direct service this last week. It is a 32-year-old multiple sclerosis patient, white female, who is in end-stage multiple sclerosis and now on hospice. How did this happen? Well, about 3 or 4 years ago, she walked into a medical center here in Sacramento and was told that there was a very helpful medication and treatment that could assist with her severe symptoms. Her insurance would not cover the treatment. So now here we are 3 years later after extensive medical bills, and this individual walking into our center for advocacy, a situation that could have been prevented. Neighbors coming in to help this woman who is now locked into a fetal position and has been in that way for the last year due to muscle contractions connected to a multiple sclerosis condition that could have been prevented had her insurance helped cover it. So I wanted to bring that story to our committee today because we hear this all the time. And it's easy to be here and to hear the data, and yes, the data is important. But yesterday I spoke with the UC Davis policy students, and I said, you know what, when you come to these tables and you put a pen in your hand and you sign off on a decision, remember that there's a human being behind that. If we remember nothing else for this year of service at this table, can we please remember individuals like this 32-year-old who is now on hospice? Because medical costs, lack of insurance, she had insurance, good insurance, that would not cover a medication that was probably outpriced because of what Stephen brought to this table earlier. We must remember why we're here. And so I'm hoping that that comment in a wrap, that we will carry that with us for the rest of this year of service.
Thank you very much, Carolyn. And it's so important for us to remember that each of these numbers represents many human beings, our neighbors and our loved ones, and always want to remind people anytime health coverage denies services, whether it's because of not medically necessary or not a covered benefit, people have appeal rights. And so it's always tragic that folks don't get to an advocate in time. Thank you for reminding us of the human impact.
Thank you. So noting for the record, we have two committee members that have joined us virtually. We've got Mike O'Day and Iftikhar Hussain. So they've been on for a little while, but just having that noted in the record. Here, I will turn it over to CJ Howard for an update on the behavioral health out-of-plan spending.
Good morning. My name is CJ Howard. I'm the Assistant Deputy Director over the Healthcare Spending Targets Branch. Andrew Fair, Research Manager in the group, and I will be sharing updates on the behavioral health out-of-plan spending analysis that the office has been engaged with for the last better part of a year and a half or so. So next slide. So some of the initial interest in this topic emerged from concerns that a large share of behavioral health spending was out of plan. The related research using commercial claims data from 2008 to 2016 found that the share of spending out of network, so not out of plan, but out of network, for behavioral health increased from 12.6% in 2008 to 2010 to 34.4% from 2014 to 2016. The Board and Advisory Committee raised concerns that OCA's total healthcare expenditure data collection does not and cannot include out-of-plan spending. In an effort to remedy this limitation, OCA contracted with Mathematica to use the California-specific Agency for Healthcare Research and Quality Medical Expenditure Panel survey and the household component to estimate behavioral health out-of-plan spending for Californians. The analysis focused on behavioral health in light of research suggesting that a growing share of behavioral health providers do not accept insurance and that patients may struggle to find in-network behavioral health providers. I'll hand it over to Andrew to share the analysis that we were able to conduct and some of its limitations.
Thank you, CJ. So as CJ noted, the Mathematica team used 4 years of MEPS household component survey data, and this is a really rich survey resource that includes information from consumers regarding their health insurance coverage, as well as their utilization and the costs associated with that utilization. And so for this particular data source, so they started with looking at spending data for each medical event. And so this could include everything from office visits to inpatient stays to outpatient visits. And so for each of those events, the data show spending by coverage type. So if you have commercial insurance or public coverage, as well as self-pay, so out-of-pocket spending. And then each event also includes the type of provider, diagnosis codes, and then procedure codes. And so in this particular analysis, the Mathematica team used the following event files. So hospital inpatient stays, ER visits, office-based medical provider visits, outpatient visits, and home health visits. We can move on to the next slide. This is just a little bit busy, but we're just here going to try to describe and outline how the Mathematica team used the MEPS data to measure behavioral health spending and then out-of-plan behavioral health spending. And so for the analysis, an event was considered a behavioral health-related event if it met one of the following 4 criteria. The event included a diagnosis code or an ICD-10 code within the code range for mental, behavioral, or neurodevelopmental disorders, or included a diagnosis code in the clinical classification software, refined category mental or behavioral health disorder, or the type of care reported by the respondent was categorized as psychotherapy, mental counseling for an ER outpatient or office-based visit event, or the type of medical provider seen during an outpatient, office-based, or home health event was categorized as a behavioral health provider. And so it's obviously quite difficult to precisely measure out-of-plan spending, and the MEPS is not different from any other data source in that it doesn't include an explicit out-of-plan spending variable. But to try to capture that concept, the Mathematica team defined an expense as out of plan if that expense was 100% paid out of pocket, and conditional upon being 100% paid out of pocket also potentially would have occurred after the deductible had been met by that particular consumer. Otherwise, the expense would be considered an in-plan out-of-pocket expense. Next slide. So survey data suffers from a number of limitations, in particular for the MEPS survey data vehicle here. It captures healthcare spending and utilization among the U.S. civilian population that live in non-institutional community settings. So any utilization that were to occur in, say, an institutional context would not be included, as those respondents are not part of the MEPS panel. So if somebody, for example, were to be in a rehab facility, a nursing home, a residential mental health treatment center, residential drug or alcohol addiction treatment centers, and the like, they would not be part of or impaneled in the MEPS survey. MEPS is again a survey, and so any information elicited is going to be voluntarily reported. And so mental health services are commonly understood to be quite sensitive to share. Certainly with the context of a survey, and so you could potentially expect to see underreporting due to stigma, confidentiality, or lack of recall. And then finally, the MEPS has a large nationwide sample to the tune of about 20 to 30,000 respondents, but once you get down to state level survey samples in the California context, depending on the year, it could vary from anywhere from 2,000 to 3,000 individual survey respondents. Next slide. So on the note about sample size here, so on this slide, we're just going to show the count of survey respondents for different parts of the analysis. So across the 4 years, the California sample was largest in 2019 and 2020, with the equivalent of about 3,200 survey respondents, but fell to about 2,200 in 2022. And then looking at the number of survey respondents who reported behavioral health expenditures, that number ranged from about 217 to 323. And then finally, the number of survey respondent equivalents who reported out-of-plan behavioral health expenses ranged from 41 to 45 during that 4-year period. I'll note, per AHRQ guidance, published estimates are recommended to be based on an unweighted sample of at least 60 respondents. And so as such, on the forthcoming slides that include these estimates of out-of-plan behavioral health spending, we do urge caution when trying to draw any conclusive inferences. Next slide. Okay, so we'll now present some descriptive statistics on estimates of behavioral health spending in California. So you can see here from 2019 to 2022, the MEPS data suggests that behavioral health spending fluctuated between increases and decreases. But over that 4-year period from 2019 to 2022, it's estimated to have declined by just under 30%. Over that same period, out-of-plan behavioral health spending estimates suggest an increase of about 50%. From 900 million in 2019 to about 1.4 billion in 2022. And then that final column from 2019 to 2022, out-of-plan spending as a share ranged from 6% to 14% across those years, and then overall, when pooled, about 10%. So well below that 30% data point previously mentioned that was corresponding to out-of-network spending. Next slide. So as noted, one of the limitations associated with the state level MEPS data centers on a relatively small sample size. And so this slide tries to kind of just illustrate the extent to which that sampling variability plagues the survey data. So because of that relatively small number of survey respondents who reported behavioral health and out-of-plan behavioral health spending, the estimates yield rather wide confidence intervals. So basically the range of values that one can't reject is wide. Which in turn prevents analysts, stakeholders, policymakers, et cetera, from being able to conclude whether behavioral health spending is increasing or decreasing from 1 year to the next, which was one of the primary use cases that motivated some of this work back in 2024 and 2025. So for example, just to kind of tease this out with concrete numbers, in 2019, while the point estimate suggests that behavioral health spending was 14.3 billion, the standard errors are such that behavioral health spending could be as low as 8.5 billion or as high as 20 billion. And then along the same lines, on the out-of-plan behavioral health spending front, in 2019, it could be, the point estimate was 918 million, but the standard errors were such that behavioral health out-of-plan spending could be as low as 260 million or as high as 1.6 billion. Next slide. So we don't have any, at least as far as we know, alternative data source that could speak to out-of-plan behavioral health spending, but as has been noted earlier, HCI houses the Healthcare Payments Database, or HPD, which allowed our research team within OCA to explore in-plan or covered behavioral health spending across the 3 major markets, commercial, Medicare, and Medi-Cal. to assess the extent to which California-specific trends estimated through the MEPS are consistent or inconsistent with administrative data. And so as you'll recall, that previous slide from 2019 to 2022, the MEPS data suggested that behavioral health spending in California fluctuated between increases and decreases, but overall declined pretty substantially over that 4-year period. By contrast, when we look at the HPD data, which is a much more comprehensive sample size as well as comprehensive coverage, you see that behavioral health spending steadily increased from about $9.1 billion in 2019 to $11.6 billion in 2022. And so one of the takeaways here then is that given that the MEPS estimates for in-plan behavioral health spending conflict with administrative data, it does give us further pause in trying to use MEPS data to estimate out-of-plan trends where the sample sizes are markedly smaller. And before passing it back to CJ, I'll just briefly summarize some of the board feedback when this topic was shared back in November. So one board member noted that they often hear that behavioral health providers limit insurance because of low reimbursement rates. And this board member further noted that it appears we've reached the limits of what can be gleaned from available data, but this nevertheless remains market failure that we need to understand. And then 2 board members noted that the results are useful insofar as giving a sense of magnitude, namely that out-of-plan spending is a problem, but perhaps not a huge 30 to 40% of total behavioral health spending problem that was initially believed. And given that one of the board members is sitting next to me, I'll see, Ian, if there's anything else you'd like to add. And nothing else from Ian, so I'll go ahead and pass it back to CJ.
Thanks, Andrew. So as Andrew has described, we found that the MEPS cannot reliably estimate trends in aggregate behavioral health spending in California and showed trends at odds with the administrative claims data from HPD. That doesn't mean that we're necessarily ending exploration of this topic. OCA intends to work with other institutions and organizations to make further progress in understanding and quantifying out-of-pocket, out-of-plan behavioral health spending. We're hoping we've had some initial scoping discussions and potential additional scoping discussions with the California Healthcare Foundation. We've, as well as other entities, and then we've also met with CPEN to have some discussions around this. So it's not necessarily done, but we do think that we've reached the terminal end with trying to glean what we can from MEPS data.
Thanks for this. It is fiendishly difficult. Just one comment I would make is I think since the pandemic, there's been a huge growth in online behavioral health services and they're marketed direct to consumers. In fact, driving up here today, I think BetterHelp must have had 3 or 4 ads in the space of an hour on my podcast for mental health services. Maybe it's just targeted to me. I'm not sure, but
we're in the same boat then.
I'm always, when we think about healthcare services, if they're self-referred, I think the dynamics are a little bit different when we think about affordability and cost effectiveness. So I think this is useful to size it, but I wouldn't burn too many calories because I think in this category we've got a significant amount of self-referred, maybe not medically necessary, maybe not even clinically that strong, being offered by a lot of different startups and firms who provide online behavioral health counseling of some kind or another.
Thank you. Samana and then Sarah.
Coda to what David's comments just were. On the referred and paid side, I haven't heard anyone else bring up this issue of the VC-funded national behavioral health organizations. Just the anecdotal thing I brought up about a local clinician who could not get onto any of the payers because she was told that there wasn't a demand locally, so she had to join that large company. This is something I'm seeing across the board, that the only access we can get now is through the larger aggregating behavioral health players. And then the other side of it, driving up, I'm listening to the Morgan Stanley, there's an Anthropic release, big LLM thing the last couple of days on healthcare to consumer. Combine all your data, put it online with us, and we will support your clinician providing better diagnoses across the board. So without any validation, we're going from here to straight up your LLM will now take over your care and the behavioral health. We're here trying to do this right. And we have these kind of rapid moves encircling us around what it's going to take to do primary care with good behavioral integration at high quality. Yep, just throwing out, I don't have answers, but the trends are just moving faster than we can keep up with.
Thank you, Sarah.
I definitely think it's important to keep looking into this issue, obviously with other sources of data than MEPS, because my impression is it is a large amount of behavioral health care does occur outside of the healthcare system or the insurance covered system. One thing I was wondering about, and I remember it was almost 2 years ago, but when I renewed my marriage and family therapy license, the BBS, the Board of Behavioral Sciences, had a questionnaire that I believe they were giving everyone when they renew about maybe practice location or if they accept insurance, and if that data, if that's data that we can use, because that would be all of the master's level mental health therapists in the state, and then the Board of Psychology. I don't know if they're doing something similar for psychologists, but also partnering with professional organizations like the California Association of Marriage and Family Therapists. Maybe they would be interested or more than happy to work with the state to engage their members and get an idea, do a survey, or even unions that work with mental health professionals. I wanted to note that this may not be directly getting at the out of plan spend, but even comparing statistics regarding the behavioral health care provided, when you compare specific diagnoses or demographics. Let me see if I can explain this clearly, but like if you're looking at like Medi-Cal versus like employer provided or covered California health insurance, and if you look at like one diagnosis, let's say major depressive disorder, what are the rates of people receiving what kinds of care? Does it vary by the demographics of the patients? Kind of looking at where things aren't similar and why is that? I mean, I know that's a little bit, I guess, vague, but in my experience working in both the private and public sphere in mental health, there's different rates of, anecdotally, I've observed different rates of care coverage and well, just overall provision of care depending on what setting I'm in and what kind of insurance or whether it's public or private. And that can maybe help give an idea of what isn't being provided and should be provided. What is the standard of care for certain diagnoses that isn't being provided? Right now working at Solano County Family Health Services, I'm thinking all of those patients that can't get mental health care, they can't afford to pay out of plan or out of pocket. I mean, they are on Medi-Cal or are uninsured. So the problem is even bigger than just out of plan spending. It's the large number of people who can't even afford out of plan spending when they can't get in plan care. And just like a quick note on the online only therapy businesses, a lot of insurance companies actually refer to these businesses. So it's not all self-referred. When I worked at Kaiser, instead of seeing patients with Kaiser clinicians, we would refer out a lot of people to these companies like Rula, and I forgot all the names of them. And also self-refer doesn't mean not medically necessary. In fact, the clinician who meets with the patient really should do their assessment. And if the person can't benefit from or doesn't need therapy, ethically and legally, they shouldn't be providing it. So self-refer doesn't equal not medically necessary. But those are just all some thoughts that I had. Thank you.
Thanks very much, Sarah. And I want to, appreciate all the comments from David and Sumana and from you on the workforce data. A different part of HCI actually worked with the Department of Consumer Affairs to get that data. So 16 of the Healing Arts boards, including the one that you work with, we do collect data, and we have a workforce research data center that's collecting that data. I think it would be hard to extrapolate folks who say they're taking some self-pay patients, how to extrapolate that. I mean, I just want to appreciate, this is an important issue. We acknowledge it's an important issue, and I do think our small but mighty team has done the best they can with, pretty intractable situation to try to see the data that's out there. Stephen has his research agenda for CHCF. We have our research agenda for CHCF. We think this may be a place that they could help. So your ideas are very creative. And so if others are able to take it up, I think our team has kind of done what we can do, unless there's anything CJ or Andrew wants to add. Okay. We appreciate the concern about it.
And I've got Michael and then Sumana and then Barry. Does that work?
I appreciate the difficulty in calculating this. As we go forward, if we reconsider in any way, just one segment that I want to be sure we don't forget is children and adolescent. So obviously in MEPS, my assumption is there's zero representation of pediatric utilization of behavioral health. This is a large and growing segment of behavioral health utilization that we have to somehow figure out a way to quantify and include if we're ever going to go forward.
Thank you, Sumana and then David.
Just to clarify that piece where I'm concerned about the independent therapist and their ability to be independent, because I think what's happening right now is, like the organization that Sarah mentioned, payers are solving their problems by turning to the one organization. We are formally attempting to find therapists and can only find them through these large national companies that are now saying they can see you not just online, but special problem for us. So I think we just really need to keep that on our sites.
Thank you, David.
Just a clarification. Sarah mentioned that companies like Kaiser, as an example, might be referring to an online-only behavioral health provider. I'm assuming in that situation that data would be captured because that's in-network. That would be different from the out-of-network, non-reimbursed area that you've been focusing on. Is that right?
If it's a claim and it's a telehealth visit, then it would be counted.
Okay.
If it's like an employer, self-insured employer having some behavioral health carve-out vendor, then we wouldn't be able to measure that spending.
So if it's other than self-funded, if it's referred by your healthcare provider, it would be captured. If it's self-funded or self-referred, it usually would not be captured.
Yeah. If it generates a claim.
Okay.
Yeah.
Got it. Thank you.
All right, I think that concludes discussion on this item, and I'll pause here and say, in an effort to move us through our agenda today, I moved too quickly and skipped public comment for our executive updates. So apologies to members of the public that wanted to comment at that period. We will make sure that happens right now, so we'll combine this public comment period with the public comment period for the executive update. So just a reminder on public comment, we'll recognize members of the public for this agenda item and the previous item. Please reserve comments on other items for the general public comment period at the end. To ensure equitable access, we will alternate between folks present in the room and those attending virtually. Those in the room can line up at the podium. Those attending virtually can click the raise hand button. Those dialing in can press *5. We also invite you to provide written public comment at the email address posted on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the committee is committed to communication and transparency, committee members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Looking to the podium, seeing no one at the podium, looking virtually. I did see a hand raised a moment ago. Yes, I see a hand raised now. Sean Kim, you should be unmuted on our end. Please go ahead.
Good morning,
Sean, we're not
committee
able to hear.
members.
Yes.
Yeah.
Go ahead.
Good morning, committee members. My name is Sean Kim from California Pharmacists Association. As previously noted, that I would like to emphasize CPHA's commitment to supporting the implementation of SB 41 and AB 116 regarding PBM-related legislation enacted last year. As a sponsor of the PBM reform bill SB 41 authored by Senator Winner, we are committed to working closely with HCI to improve transparency of PBM practices across the healthcare ecosystem. The practice that contributes to high costs for employers, including the government-funded programs, self-insured, and most importantly, for the patients who are often most vulnerable in the system. We also congratulate HCI securing $233.6 million of budget year one for rural health transformation, expanding the access and stabilizing the workforce, modernizing the infrastructure of rural health communities. As we reviewed the project and budget narratives, we noted that although the NOFO explicitly calls out the Cicero Institute reports, which address pharmacists, workforce development, and scope of practice flexibility at community-based pharmacy and pharmacy-led care models, which focuses on preventive care and chronic disease management, were not clearly reflected in the application. This is a missed opportunity, particularly given the California's recent transition of pharmacy practice into standard of care framework under AB 1503, which significantly expanded pharmacist practice authority and closely aligned with the NOFO's intent. We also highlight that the health information technology is the critical gap. While the prior investments supported the clinics and the health system, however, the community-based pharmacies were largely excluded. California Rural Health Transport. Thank you for
2
the.
minutes. Go ahead.
Sorry. As California Rural Health Transformation emphasized the interoperability and the hub and spoke care models supporting EHR adaptation, this will be the critical investment for evergreening impact. So CPHA looks forward to continue dialogue and stand ready to support the implementation. Thank you.
Thank you. Looking to the room, seeing no one at the podium, looking virtually, seeing no hands raised. I'll give it just a moment. That concludes public comment on this agenda item and the previous executive update agenda item. I will now turn it over to Andrew Farrer on introduction to DSG 3.0 regulations.
Thanks very much. We can migrate on to the next slide. So before I get to the content here, I do just briefly want to thank the health plans and submitters for their engagement over the past year. They've been really thoughtful partners, both in submitting data and then providing feedback on how we can streamline or improve the specifications. So I expect no different heading into this next submission cycle. And looking ahead to this year or this fall, so Data Submission Guide 3.0, or DSG 3.0 as we call it, outlines requirements for submission of 2024 and 2025 calendar year data in the fall of 2026. And then very similar to last year, we released a draft data submission guide just a couple of days ago on January 5th, and we encourage public comments to be submitted at oca at hci.ca.gov by the end of this month on January 30th. Annual registration, similar to last year, will be expected around the end of May, and then data submission for all files is expected by September 1st of 2026. We can move on to the next slide. All right. So both in monthly data submitter work groups and in one-on-one discussions with plans, we've heard a desire to minimize large-scale changes to the data submission guide. So with that feedback in mind, many of the proposed changes in DSG 3.0 do endeavor to be responsive to that feedback. And we did seek to preserve a great deal of continuity in the total medical expense file layouts. But the slide does include some of the notable proposed changes, such as a new behavioral health file and payment allocation instructions. Medi-Cal managed care organization data will be required in all files. So for just a little bit of a background here, we've taken a crawl, walk, run approach with the managed care organizations, phasing in reporting requirements over a 3-year period. So in year 1, they were wholly excluded, and we relied exclusively on DHCS data exchanges. In year 2, they were required to submit the APM and primary care files, and then in year 3, we're moving towards a model where we would expect them to submit all files directly to OCA. There is this penultimate bullet here, a separate reporting of self-insured member months and spending in the statewide file only. And then last, a request to have submitters provide copies of their filed medical loss ratio reports directly to OCA as part of their data submission. And with that, I will go ahead and hand it over to Margareta Brandt.
Thank you, Andrew, and good morning, everyone. Margareta Brandt, Assistant Deputy Director for Health System Performance at OCA. As Andrew noted, we wanted to walk through a few changes we made to the APM and primary care file instructions for DSG 3.0 for the alternative payment model file and the primary care file, and these changes were made based on our experience this past year in data collection and the feedback that we received from data submitters or health plans, and where we could be more clear. So for the alternative payment model file or the APM file, we've revised language in several places for clarity. For example, we have provided additional guidance on how member months are attributed based on member months of coverage. Also, the APM file section of the data submission guide has been revised to include step-by-step instructions for expense and member month categorization, and we've added a new process map to illustrate this categorization. So for the primary care file, we have revised language in several places to improve the clarity of our instructions again. For example, we clarified primary care spending attribution methodology for non-claims payments, such as how practice transformation payments or capitation payments are allocated to primary care. We also revised language to clarify that primary care spend for the claims-based payments is reported at the claim line level, not the claim level. And then we've made a few updates to the primary care code set based on stakeholder feedback. So for example, we have added an additional physician assistant taxonomy to our list of primary care providers. And then we've also added the new advanced primary care management service codes that were released by the Center for Medicare and Medicaid Services, or CMS. And on the next slide, we'll walk through some of the proposed changes that are specific to the Medi-Cal managed care plans only. So in collaboration with DHCS and in response to Medi-Cal managed care plan questions, we have added reporting requirements clarifying which DHCS payments to include or exclude from the measurement of primary care spending. That is the numerator and denominator for measuring primary care spending and alternative payment model data collection. For example, pass-through payments will be excluded from MCP reporting, and vaccine administration fees from the Vaccines for Children program will be included. And furthermore, in the primary care file, we have revised the methodology for claims payments to instruct managed care plans to use the monthly 274 file that's submitted to DHCS in their annual network certification to determine whether a physician, nurse practitioner, or physician assistant listed as the rendering provider on a claim is a designated primary care provider in the health plan network. And this requirement is analogous to the requirement that commercial plans use their annual network files submitted to DMHC, the Department of Managed Healthcare. So we added this clarification and additional instruction to be more specific for the Medi-Cal managed care plans. And in the next slide, before we jump into more detail on the behavioral health file and our behavioral health definition, wanted to just provide an overview of the timeline for finalizing the data submission guide. So earlier this month, OCA published the draft regulations associated with the data submission guide for public comment. Following revisions based on feedback received on the draft, the DSG 3.0 regulations will be submitted to the Office of Administrative Law in approximately March and become effective in April. And then data submitters will register with OCA in May of 2026, and data submissions will be due on the first business day of September 2026. So just adding a bit more detail and context to what Andrew mentioned earlier. So we can move to the next slide. So I know we've, in our previous meetings with the advisory committee, we walked through the behavioral health definition. So we will walk through it again and share some of the feedback we received and how we are approaching that feedback. And then, so yeah, Debbie Lindes, my colleague, will summarize the public comments we received on the behavioral health definition and the board feedback as well. So if we could go to the next slide. So just as a brief reminder, OCA's statutory requirements related to behavioral health include two distinct but related activities for behavioral health spending. So first, we're required to measure behavioral health spending as a % of total healthcare spending. And second, we are tasked with setting a benchmark for behavioral health spending that sustains infrastructure and capacity and shifts resources towards supporting and facilitating innovation and care improvement in behavioral health. And as another reminder that we are continuing to work with the healthcare payments data team to analyze behavioral health spending using HPD data, and we'll come back to the advisory committee and the board later this year with refresh data and also potentially revisiting the behavioral health investment benchmark. So if we can move to the next slide. So another reminder, this is our equation for measuring behavioral health spending, and behavioral health spending is in the numerator here. So we are measuring behavioral health spending as a % of total medical expense, which is the denominator. And both the numerator and the denominator include claims and non-claims. And the numerator will also include pharmacy spending for behavioral health medications and patient out-of-pocket responsibility for behavioral health services when they are obtained through the plan. And then the denominator will include all pharmacy spending and all patient out-of-pocket responsibility for services obtained through the plan. And on the next slide, so OCA's behavioral health spending measurement methodology includes 3 modules, so claims, non-claims, and then behavioral health in primary care, which includes both claims and non-claim spending, but will be measured separately. And this is the same structure of the methodology that we use for measuring primary care spending that we developed last year. And the next slide will do another quick refresher of our claims-based behavioral health spending definition. So for the claims-based primary behavioral health spending module, these are the high-level principles on which our methodology is based. So first, all claims with a primary behavioral health diagnosis, that is a behavioral health diagnosis in the first diagnosis field on a claim, will be included in the measurement of behavioral health spending. And then in addition, claims for screening or assessment of mental health or substance use disorder services or substance use disorders will be included in the measurement regardless of whether the claim includes a primary behavioral health diagnosis. And behavioral health claims will be categorized based on place of service, revenue, and service codes on the claims, and though these categories are relevant both for reporting purposes and for identifying spending that may be included in a potentially future focused benchmark. The other service category for claims-based spending is used to categorize behavioral health claims that do not have a combination of place of service, revenue, or service codes associated with any other specific subcategory. And then finally, a set of national drug codes will determine whether a pharmacy claim should be included as either mental health or substance use disorder spending, independent of the diagnosis. And on the next slide, this slide provides a process map that you've seen before. That is the process representation of how a claim is identified as behavioral health spending. So I'll walk through this quickly. The main test, of course, is whether the claim includes a behavioral health diagnosis as its primary diagnosis. And the exception is when the claim is for screening or assessment of a mental health condition or substance use disorder. And the service categories in the center of the diagram are defined by place of service, revenue, and service codes. And these are used for reporting and analysis. So once a claim is determined to have a primary behavioral health diagnosis, this categorization has no bearing on whether the claim is included as behavioral health spend, just how it's categorized in our reporting. Pharmacy claims are separately determined to be behavioral health spending based on national drug codes, as noted, and also importantly, want to emphasize here that all claims can be identified as either mental health or substance use disorder claims, so that this spending can be measured and reported separately. And on the next slide, we'll want to just overview of the behavioral health service subcategories that we will be using. So this slide shows how we recommend the behavioral health service subcategories from the process map on the previous slide be rolled up into higher level categories. So the categories would be used for reporting and for identifying spend that can be measured against a future benchmark. And another note here is just to reiterate, the other category would be used for claims with a primary behavioral health diagnosis, but without any other identifying codes to place them in a defined category. And moving to the next slide, we'll turn to our next module, which is the non-claim spending module. So these are the principles on which OCA's methodology is based. So this measurement will involve a variety of methodologies for allocating some or all of a non-claims payment to behavioral health. And non-claims payments will be classified using the HCI Expanded Non-Claims Payments Framework. This is also the same framework that's used to classify non-claims payments for our OCA total medical expense, alternative payment model, and primary care spending data collections. The various methods for allocating non-claims payments to behavioral health include classifying payments for population health, behavioral health integration, and care management as behavioral health only when these payments are made to behavioral health providers, limiting the portion that can be attributed to behavioral health from payments for practice transformation, information technology, infrastructure, and analytics. And then including all of the behavioral health capitation payments as behavioral health spending. And then for other types of capitation payments, allocating a portion of those payments to behavioral health using a formula similar to the one adopted for allocating capitation payments to primary care, which relies on using encounter data. And all non-claims payments identified as behavioral health spending will be included in our measurement of behavioral health spending. And then going to our third module, which is measuring behavioral health in primary care. So measuring spending for behavioral health delivered in primary care settings as distinct from the other measurement of behavioral health services is intended to promote policy priorities such as the expansion of integrated care and greater attention to preventive behavioral health care. So OCA is proposing to measure behavioral health care in primary care through its data collection and then also by using the Healthcare Payments Database, or HPD. And this dual approach will optimize our ability to understand this aspect of spending while also aiming to minimize administrative burden on data submitters. And on the next slide is our proposed approach to the behavioral health and primary care module. So After several discussions with our investment and payment work group and review of public comments on this module, we have landed on taking a phased approach here. So for the module, in our data collection in 2026, which is the first year data submitters will provide behavioral health spending data, we will capture a portion of behavioral health in primary care spending focused on care delivered by primary care providers. And the measurement will include claims-based payments within the outpatient professional primary care subcategory and non-claims payments for primary care and behavioral health integration. And all of these payments will also be captured in OCA's primary care spending measurement. And then in the longer term, over the coming year or so, we will conduct iterative analyses using the HBD to explore how to refine the methodology, including integrated behavioral health care provided by behavioral health clinicians who are not currently part of our primary care definition. And these refinements would include potentially an expanded list of primary care provider taxonomies and perhaps additional services such as psychotherapy. And we hope that these HPD analyses will give us insight into how to bring additional legitimate integrated behavioral health spending into this module without overcounting non-integrated behavioral health services. So that's the tension that we're trying to assess and come to a solution for. And now I will turn it over to Debbie to summarize the feedback we received from the board in our November board meeting on our behavioral health spending definition and methodology.
Great. Thanks, Margaretta, and good morning, everyone. Barely. I'm Debbie Lindus, Healthcare Delivery System Group Manager at OCA. And in these next two slides, I'll summarize feedback we received from the board during its November meeting. Board members recommended prioritizing incorporating Medi-Cal County behavioral health spending into our measurement. And OCA is collaborating on an ongoing basis with DHCS and with HCI's HPD team to establish a data source and methodology for including county behavioral health spending into its measurement and reporting. Similar to the advisory committee, board members asked to hear more about OCA's approach to measuring out-of-pocket, out-of-plan spending on behavioral health services. And as you've heard just a few minutes ago, OCA has explored using medical expenditure panel survey data to estimate out-of-plan spending, but unfortunately these estimates are not as reliable as we'd hoped, and therefore OCA plans to work with other institutions to make further progress on this important effort. We heard a concern that measurement of screenings and assessments might lead to overcounting of behavioral health spending associated with preventive visits. And OCA clarified that when the primary diagnosis on a claim is not a behavioral health diagnosis, only any amount paid for the screening and assessment claim lines counts towards behavioral health and not the entire claim. A member asked about OCA's ability to attribute behavioral health spending to provider organizations. And our response here is that OCA collects behavioral health spending at the plan level, and our methodology does not attribute that spending to provider organizations. Some additional feedback on the next slide. Board members expressed an interest in knowing how commonly psychotherapy services are provided without a behavioral health diagnosis. And to answer this, we can consider HPD analyses to evaluate how often common behavioral health services, such as psychotherapy, are provided without a behavioral health diagnosis on the claim. And finally, a board member asked whether OCA's measurement will capture payments made to third-party vendors. OCA's methodology captures both claims and non-claims payments to providers that are made by health plans. And so this includes payments to telehealth providers and other third-party vendors. But payments made outside a health plan, such as directly by a consumer or through an employee assistance program, for example, are not captured in OCA's measurement. On the next slide, I'll review some of the updates we've made in response to the input from the board, the advisory committee, and public comments, as well as through ongoing internal review. So these changes for the upcoming 2026 data submission guide include some updates to the outpatient professional primary care subcategory, which is being used to identify behavioral health care delivered in the primary care setting. We removed some codes from the Milbank Memorial Fund code set that served as the starting point for OCA's definition to align this subcategory with OCA's vision and existing definition of primary care. We incorporated some new service codes, including new codes from the 2025 and 2026 CMS physicians fee schedules, such as care management services for behavioral health conditions. And we added some service codes based on feedback from DHCS and also updated screening and assessment codes based on a review of DHCS coding manuals. On this next slide, some of the updates to our behavioral health measurement approach that pertain specifically to Medi-Cal include adding a methodology to capture behavioral health spending for Medi-Cal members under age 21 to reflect Medi-Cal policy that for youth, a behavioral health diagnosis is not necessary to receive behavioral health services. As has been mentioned already, Medi-Cal managed care plans will submit behavioral health spending data alongside commercial and Medicare Advantage plans in 2026. And OCA is continuing to collaborate with DHCS regarding incorporation of county specialty mental health and substance use disorder spending through the Drug Medi-Cal Organized Delivery System program. And on this last slide, I'll wrap up this agenda item with our timeline for behavioral health spending measurement. OCA's draft data submission guide for 2026 is currently posted for public comment, and the final guide will be published in the spring in preparation for 2026 data submission at the beginning of September. So OCA will include results of its analysis of the 2024 and 2025 behavioral health spending data in its 2027 public report. And throughout this time, OCA will continue to collaborate with DHCS and will also engage county behavioral health plans to prepare for future reporting of Medi-Cal specialty mental health and substance use disorder spending. And on the next slide, we'll pause for any comments or questions the committee has on the updates included in the data submission guide.
Simona.
Yes, I feel like I might be missing something and might just need explanation. Why should a primary care clinician consider the importance of moving this behavioral health diagnosis to the first physician? Like, so much that we're talking about rests on that's how you are going to measure behavioral health in primary care, and so much is the importance of that is clear. But from my perspective as a busy family doctor, I guess I just don't understand why I need to do that. What's happening here that I must do this?
Yeah, that's a great question and a limitation of our methodology that if we were to include a behavioral health diagnosis regardless of where it occurs on a claim, then we would probably be overcounting some care that really isn't behavioral health focused. And so we're it's a trade-off of overcounting, undercounting when we're currently planning to include only primary diagnosis.
I see that, but the essence of complex, high-quality primary care is that it is deeply integrated already. I have no clue whether I should consider that diagnosis first or not, and I've already brought up multiple examples of this, like headaches or pain of any kind, or, right? To do this well, I could go on and on about how much better we could do it if we integrated that care, paid for that care, acknowledged the additional time that care takes. This seems very simplistic for the kind of care that I'm already providing that isn't reimbursed in this context.
Thank you. Thank you for that. And we really appreciate that the nuance that's there and is difficult for us to capture with our data collection. We are intending to look at HPD data to kind of study how the distribution of the position of behavioral health diagnoses is in primary care claims data to better understand how that works. And yeah, so right now our kind of approach for the first round of data collection is if it's the primary diagnosis, the primary reason for the visit.
Almost have to point out that it's going to be 90% of the time way lower because it's, you know, primarily the health conditions the patient voices, while the clinician recognizes the importance of depression or anxiety, or even that this, you know, it's how we prevent those emergency visits. It's how we, but they're not coming in for that most of the time. So I think that research almost has to happen first. And I'm concerned that I can't get enough of a grasp of how this works or how you're even going to measure the joint payment issues. That part's really troubling me.
And Samana, it's always very helpful to hear your perspective. And just to be clear, I mean, we're not telling primary care providers how to do their coding, and you have a lot to consider. And we do think it's important to try to capture some of the critical behavioral health work that we know primary care providers are doing, and to value the whole person care that we know you provide and that you're very articulate about lifting up. So the data we think is important to try to do the best we can to capture it. And we're not trying to change the way you're coding things. So, but appreciate your points.
Okay, we've got Michael, Andrew, David.
So I'll just briefly pile on to Sumana's, sorry, but a very real example that's high volume would be well child visits in a child who has attention deficit hyperactivity disorder. We're not going to code ADHD first. We're going to code the well child visit and all that goes with that. But we may spend a half an hour or 20 minutes reviewing meds and that type of thing. So just food for thought on that. And then just, Margareta, just a quick question. Are the cost considerations inclusive of dyadic care codes as well and payments?
I mean, yes, I think we have looked at those codes and included them. Yes.
Thank you. Andrew and David?
Yeah, sorry, I'm going to add to the pylon, but I think just understanding how much, the dollars that are not in the primary is going to be key through HPD data, once the team has gone through it. The other thing is maybe just to jog my memory, and the reference to under 21 kind of jogged my memory a little bit. Are we counting autism-related services as part of this, or is that separate? I'm just wondering.
Autism-related services are in the definition in our code set.
Yeah, in our behavioral health code set, and then the behavioral health and primary care code set right now is only services that are provided by a primary care provider in a primary care place of service. So some autism services will certainly fall in there, but others may not.
Thank you. David and then Hector.
Yeah, I'm unfortunately carry on with the pylon. I think one thing, we're dealing with the consequences of the way mental health parity was originally implemented here in the state, where much of the behavioral health was carved out to separate companies, vendors, who manage this. I think the problem is that I think most primary care physicians would say most patients who have physical and mental needs, their care is most often best delivered by primary care and behavioral health integration, which either means the primary care physician is helping with the behavioral health or they're well integrated with the behavioral health provider, neither of which really happens today very well because of the carve-outs. And I think the problem with what Suma was just saying is I think if you put behavioral health diagnosis on the claim as the primary diagnosis and send it to most of the health plans, they'll reject it and say, no, you've got to send it to the behavioral health vendor for reimbursement. So I think unfortunately, I don't know that we have a way to capture the behavioral health being done by primary care physicians, which is extremely important and valuable. Because I think if you ask them to put it as the primary diagnosis, I think you get that unintended consequence. So I don't have a good solution, but I'm furthering the complexity.
Mm-hmm. Thank you. Hector, Adam, and then Suzanne.
So I'll add to the rugby scrum, the pylon. from a couple other additional perspectives, everything that's been covered is right on. One of the dynamics we have in the delegated model is that IPAs may not approve, let's say the case that Dr. Suman already mentioned, severe headache, has had multiple visits to emergency room for severe headache. At some point, somebody has to order imaging for that patient. But in the interview and examination, we also identify behavioral health issue as contributory to the headache, but we still got to rule out a major condition. And for the benefit of the patient, give them peace of mind that we explore all the medical reasons while we treat the behavioral health issue. The IPA and the delegated model, and even in the direct model with health plans, they will not honor that request for imaging, say it's an MRI, if they don't see that the headache is severe enough that it warrants that study. If they see behavioral health, they're going to push it right back and say, not approved until you figure out if it's behavioral health origin. So really important issue there. The second thing is that, we're going through this process of Prop 35 targeted rate increases that include behavioral health provided in a primary care office. And I can tell you in LA County, we have a Medi-Cal committee as part of the LA County Medical Association. And almost universally, the physicians who are members of that committee and their colleagues in the community say they're not getting paid for those targeted rate increases across the board, including behavioral health. And two, they may be getting partial payment, but they don't know what they're getting paid for. So some of the data that you really need to collect has to have the accuracy that the right diagnosis, the right code is being submitted, and hopefully that also will result in the physician getting paid. So that's another major issue is the targeted rate increases. The way that data is being collected and paid for is really unsatisfactory. I have a separate meeting coming up with the California Medical Association on this very issue, and hopefully we'll have some clearer questions to ask and collaborate with you, Margarita and Debbie, to go with DHCS and say, here's a list of problems that we need to address. The second thing is from the federally qualified health centers and rural health centers. The challenge they have is that they're often providing a behavioral health issue by having the primary care clinician walking the patient down the hall to the behavioralist, but they're not allowed to get paid for same-day services because the state sees that as double dipping, two bills for the same visit when they're actually two separate visits. So on behalf of the safety net clinics, the same day issue also needs to be cleared because they are providing the service and currently not getting paid. Thanks.
Thank you. Adam, Suzanne, David.
So, very well said from the fellow clinicians in the room about the tension and the friction. I think the parity solution is kind of come to a head here, where continually exposed, whether it's through our clinical education or clinical exposure about the interaction, new evidence-based data, now all our new therapeutics, and really we're coming to a point where I think we all have consensus about what we want to see and how we want to deliver the care, but that's not how the insurer sees it or our health system sees it even from my view in the emergency department or my colleagues in emergency care. Even if a behavioral diagnosis makes it onto the chart, it's pretty significant given the degree of other comorbidities that we have to deal with. So, to even get there, and I'm sure it's the same in primary care, it's incredibly telling. Even if we can't, do anything about it, it is intricately, influences all the other that are being delivered. So, it's thinking about, I guess, from a higher level, if we have this consensus and we know there's a gap, not capturing it may actually benefit us, because if we have a adequate benchmark, that means we're too far away from the benchmark anyway. So, by identifying a gap, even if we're underestimating it, it may, help us get there in a roundabout way to include that investment and reinforce the importance of that effort and investment, whether it be, psychotherapy or some of these new longer-acting injectables, whether it's substance use or mental health, that I would like to deliver in the emergency department, can't because of costs, prohibitive costs, whether it's payers or
I have a absolute appreciation for what everyone shared. I just wanted to also acknowledge the work that you guys have done, because I think, and the details are the most important thing, but I think at the highest level, to me, it feels like a lot of what this push is doing is trying to ensure that there's a not just adequate but sufficient amount of behavioral health treatment and spend and access. And so I do recognize that this work is really valuable. Separately, maybe it's a question is on the primary care work. I know that's maybe more so pushing for a percentage of care, again, at the highest level, but is there work in that work stream, and maybe we've covered it and I just am not recalling at the moment, about integration of other types of care or the quality or type of care at the primary care level, which would therefore then include some of these items and the importance of behavioral health integration?
Sure. So I think at the highest level in our primary care definition, we are aiming to capture spending for all types of integrated care, whether it's social services or behavioral health. I think the challenge is the nuance of capturing that. So, we do include providers like community health workers in our definition of primary care, and aim to capture, integrated services and other types of services through our non-claims payments, if that's how those payments are occurring. So our goal is to capture kind of as broadly as possible the integration that is occurring in primary care settings, I think with the limitations of claims data and non-claims data as it's collected by OCA.
Got it. Thank you. And it may be interesting then to see in this, not this model and work, but in the primary care one, as it gets further down the road, to then maybe see with some ideas that have been raised today, because diagnosis codes or CPT, other codes that may indicate behavioral health, maybe that could be something that could rise to the top as being not just the percentage of primary care in the market, but also then what type of care is it? And I know that opens up a whole nother can of worms, but it does sound like it's very important to the committee members as well as myself to make sure that there is behavioral health integration there. Thank you.
Yes. And with the behavioral health and primary care module, our goal is, given limitations and given our, inclination to not overcount behavioral health spending, is to try to capture integrated behavioral health in primary care and report that data distinctly so we can understand, at least based on our data collection methodology, how much spending is occurring for behavioral health in primary care.
Thank you. David and then Sarah.
Just one more comment from me on this. So we've had this situation in the state for so long, it's easy to forget the fundamental issue. So if you're a primary care physician today and you refer a patient to a specialist, say it's orthopedics, endocrinology, pick your pick, you will recommend to the patient usually a specific clinic or a specific doctor. That patient goes, you have some idea whether they're seen by that clinic, you get feedback, the notes come back to you as a primary care physician, so you know what's going on. Primary care physician is the quarterback for the patient. And I think the value of that is why we're emphasizing in OCA primary care expenditure, because we think that more of that is a good thing for total cost of care, and I agree with that. Contrast that with the way behavioral health works today. If you're a primary care physician, you say to the patient, your behavioral health is managed by XYZ company, that's behavioral health carve-out, and you need to call this 800 number or go to this website to get your referral. And usually the primary care physician will not know which clinician is seen, and they also don't get any feedback of any kind. And so it's become this sort of very unfortunate black box. And it's been well documented that for patients with serious chronic illnesses, many of them will have mental health challenges that come along with that. And if those are treated, they're more likely to do better with their behavior, with their chronic illnesses. They're more likely to have medication adherence. They're more likely to follow up with treatments and tests and so on. And so, as we think about the big picture here, I think behavioral health done well integrated with primary care can actually reduce the total cost of care. And that's what we should keep in mind. And I think as OCA has, an HCI has maybe policy influence over this, I just wanted to bring this contrast between how crazy is it that every other specialist, there's this very well working process, and behavioral health is like this unintegrated, no communication process. And that just doesn't make any sense. And can we as a policy perspective, can we try to influence that?
Thank you. We've got Sarah and then Silvana.
I actually really liked what David said. I think he's right on about that. I happen to be, I mean, for the last maybe 6 months, working in a pediatric clinic, for a primary care clinic. I'm the only mental health therapist there. And before I came there, they would refer out. In our world, it's Partnership Health Plan who contracts with Carelon for mental health care. And a lot of the pediatricians would struggle to get people connected because, you know, there's more hoops for patients to jump through. Now that I'm there, it's more seamless. They refer it to me. I work with the patient. They can see my note in the chart. I can directly message them if I, you know, want to refer to the pediatrician for medication evaluation. It is better, and I think it just highlights the problem with our mental health care system in that you have additional hoops to jump through that you don't for medical care, and that's been a systemic problem in our healthcare system, that mental health care is kind of relegated off to the side. And I would say, as a clinician that's worked at various places, like I'm thinking Starview Community Services in Long Beach, which is a Medi-Cal contractor for LA County. Yes, these children had primary care doctors, but did I have any time to contact them? No, because of the poor working conditions, just trying to keep your head above water. And so there's so many layers to the whole system that makes it so it's fragmented and there's no communication. And I was going to note a couple things that the other thing, I can see the intricacies about all the diagnoses that primary care physicians and pediatricians write, that there's probably even multiple medical conditions, but only one can be that first diagnosis. But I could see how, you know, there is that concern of overcounting, and that I notice the pediatricians who see my patients in our clinic, they'll always add that behavioral health diagnosis, even if it's just, and this is important, but it just to, you know, oh, you're still seeing Sarah, how's that going? Like, just, you know, making sure, but noting that, yes, this person has this diagnosis, but maybe in that visit, a significant amount of time wasn't necessary for addressing the behavioral health condition. And I wanted to note that even with adults with Medi-Cal, with CalAIM, they can receive services without a diagnosis as long as there's a suspected diagnosis while you're in the assessment process. I mean, that may in the end be a small portion of the services, but that also is the case. Let's see. Maybe the other thing I was noting, this is just maybe a question for me, kind of getting an understanding. I don't know why I have a hard time with this, but the difference between preventative behavioral health care versus integrated behavioral health care. So I'm in that pediatrics office, but they bill Carelon for me. I, provide individual therapy. So I'm providing behavioral health treatment. I mean, I would consider it preventative in that if they get this treatment now, they're going to prevent a decompensation or worsening of their, condition to need maybe a higher level of care. But I don't know if that's the true meaning of preventative versus like dyadic services or screening. And just an interesting note, my clinic has not allowed me to do dyadic services because of the lower reimbursement rate. They are saying that individual therapy provides a higher reimbursement rate, but the value of dyadic services is very high. So maybe there's some competing like perspectives on, and maybe the work of this office is going to make the difference to encourage more dyadic services to happen. Oh, the other thing I wanted to ask is, even if the behavioral health diagnosis isn't the #1 diagnosis with primary care clinicians, if there's a behavioral health screening that occurs during that visit, wouldn't that still count for, so it's not like it has to have a behavioral health diagnosis first. If there's like a screening for like depression, then that will count as behavioral health.
Yes, screenings and assessments for behavioral health conditions count towards the spending for both primary care and behavioral health in without a diagnosis, and it's captured at the claim line level. So yes, so if there is spending associated with that claim line level, yes, it will be captured. And I think, Sarah, to your point about integrated care, I think, you know, what we're aiming to incentivize is care, I think care very similar to what you were describing in terms of your clinic setting. So that's our, you know, kind of overarching look at how do we incentivize that type of care integration in primary care. And I'm sure there's other nuances and pieces to that, but that is the type of care that we are aiming to incentivize through the behavioral health and primary care module. And I think are more generally talking about broadly with the behavioral health investment benchmark, how do we you know, incentivize or increase investment in kind of overall preventive behavioral health care. Kind of loose definitions, but we would be happy, especially as we approach conversations again about the definition, to be more clear about what we mean there.
Simona, and then I think we'll wrap this item.
I really appreciate the clarifications around, you know, of course I understand the impetus, the importance, but I'm always thinking about the workflows and how that's going to impact practicing clinicians. So the policy signal, as David brought up, is the critical thing here. And I think my concern really wasn't aimed at this process at all. It was going a few steps ahead to where the payers lead with it. Because a lot of you are talking about these screenings. This year, what do we get told? A whole process to screen everyone, of course, document and use specific codes for the positives in that screening. And then we are to be held to a 50% rate of, with that screening, are we documenting that they have follow-up within 30 days? Well, if it's not follow-up with us on our absolutely jammed schedules, it's to be with the therapist that we haven't yet referred to, right? With some kind of magical understanding that they're going to be able to see them within those 30 days. So the payers are far ahead of our ground reality, and I just expect to be ground down by their solution being that it will come back to us. So I'm waiting for that next step, the shoe to drop, you know, on what is going to be expected when they have more pressure to expand access, right? So I'm just taking it to that level and pointing out it's why I'm really concerned that we look at what it means, like the moment we start measuring, what are we going to do with that measurement and how are we going to work these workflows? What does it mean? And I want to talk to Margarita on the side about that. We've got these different investment and payment work groups for these two things. What are we looking for future?
That concludes the discussion on this item, and we will now move to public comment on this item. If you'd like to make a comment, please step to the podium. If you're attending virtually, please raise your hand. Please keep your comments to 2 minutes or less. I see Sean Kim, your hand is raised. Please go ahead.
Hi, committee members. Sean Kim from California Pharmacists Association. I would like to provide a comments about DSG 3.0 to better capture healthcare spending associated with pharmacy-related medical benefit billing data at pharmacies. As California transitions towards to team-based and value-based care, pharmacists are increasingly delivering primary care and preventive services, such existing practice authority to Medi-Cal and Medicare and commercial payers. We encourage OCA to ensure that APM and primary care file guidance does not unintentionally exclude pharmacists deliver services such as medication therapy management, MET, medication-assisted treatment, behavioral health screening, chronic care disease management, immunization including BFC or BFA, and preventive cares, which is the part of the coordinated care. We appreciate the clarification of primary care attribution methodologies and the expansion of taxonomy and the services code, including PAs. We encourage OCA to continue evaluating whether additional provider types and taxonomies, such as pharmacists practicing under the authorized scope, should be considered in the future iteration to better reflect the multidisciplinary care delivery. Thank you so much for letting me comment.
Thank you. Looking to the podium, seeing no one at the podium, and seeing no other virtual hands raised, that concludes public comment on this item. And we are going to move to our next item on the agenda before we break for lunch. So stay with us a moment longer. I will turn it over to Brian Kearns.
Good afternoon, everyone. My name is Brian Kearns. I'm the Assistant Chief Counsel for OCA's Compliance Program. I know we are all eager to get to lunch, so I promise this won't take very long. Next slide. So this is a slide showing the amount of transactions and notices we've received in 2024 and 2025. As a reminder from previous presentations, a transaction can include multiple submissions. So under our regulations, parties who meet our requirements are required to file a notice with us. So some transactions may have one notice, some may have 2, 3, and so on. So what you can see here is we definitely saw an increased volume of transactions and submissions from 2024 to 2025, even when you consider the fact that our program started in April of 2024. You're also seeing that we had a lot of pre-filing meetings in 2024, and that decreased in 2025. And that's probably due to a variety of factors, the public becoming more aware of our program. Our team has prepared and continues to update some FAQs, which are available on our website. We have a filing flow chart that can help potential submitters understand whether they need to file a notice with us. And I actually just found out that since early 2024 to now, we've answered about 200 questions in our CMIR inbox, so we're always ready and available to answer the public's questions regarding our program. Next slide, please. Here you can see the types of transactions that we reviewed. In previous presentations, skilled nursing facilities, we've highlighted as being the #1 type of submission we get, and that trend continued through 2025. You can see other types of transactions we've received as well. In the second half of 2025, we started to see more ambulatory surgery center acquisitions, and we've noticed an increase on those types of transactions in late 2025, and we expect that to continue into 2026. Next slide. So I'll go over in the next couple of slides the transactions that are currently under review. You'll see that the slide says we have 3 additional transactions that are in review for completeness. That's actually 2 because we recently posted one. So this slide shows the El Centro Regional Medical Center's acquisition of El Centro Post-Acute Care, which is a skilled nursing facility. This transaction, like many of the skilled nursing transactions we see, involves both a transfer of operations and the facility sublease to the El Centro Regional Medical Center. Sometimes we see the transfer happen to 2 different entities, but in here a single entity is assuming control of the operations and the sublease. Next slide, please. So these are another 3 transactions. We have AmSurge acquisition of Euclid Endoscopy. So AmSurge is a nationwide organization of 250 ambulatory surgery centers. Well, we next have an acquisition by Care Meridian, which operates 19 congregate living health facilities in California. Care Meridian is acquiring the Sierra Summit Head Injury Care Homes, which is an adult residential facility in Rockland. And in the third transaction, the current owners of Physician Health Network Medical Corporation are selling their company to other medical providers to facilitate the retirement of a few owners. Next slide. This is probably the most important slide in terms of the transactions under review. It shows the two transactions that we've sent to a cost and market impact review. The first being the Covenant Care transaction. So that transaction involved the transfer of 22 skilled nursing facilities to multiple entities. And on June 6th, OCA determined it was necessary to conduct a cost and market impact review for 3 facilities being acquired by the Ensign Group. Those are the Buena Vista Care Center, the Shoreline Care Center, and the Huntington Park Nursing Center. OCA waived the remaining parts of the transaction. So the CMIR is essentially going to look at the various factors which are listed in our regulations. At a high level, those factors relate to cost, quality, access, equity, labor, and competition. So we're seeing how the transaction impacts those factors. The CMIR notice, along with all non-confidential documents that were submitted with the notice, are posted on our website. And I should note that the review is currently paused as we await the information and documents from a third party. The second transaction list here is the ResCare transaction. So in this transaction, National Mentor Holdings, which does business as Savita, is acquiring various residential care facilities throughout California, including waiver group homes and intermediate care facilities. In November, OCA issued a decision to conduct a CMIR. Like the Covenant Care CMIR, the notice ordering the CMIR along with all non-confidential documents are posted on the website. Okay, next slide. So and then the next 8 or so slides are all transactions we've waived in the second half of 2025, so I'll just quickly run through them. Resolute Holdings was associated with about 17 radiology centers throughout California. We reviewed Envision's acquisition of Resolute and those radiology centers. The second transaction involves MedImpact, which is a pharmacy benefit manager, acquiring SaveRx, which offers prescription management services to unions throughout the United States. The third transaction is CCW. It's a national merger between 2 luxury senior living communities, V Living and Life Care Services. As a result of the merger, the ownership structure of 2 California skilled nursing facilities will change. Next slide, please. The first transaction listed here is Evolent Health's transaction. It involves Privia Management Company acquiring Evolent's accountable care organization business. The next transaction is one you may have heard of. It's the result of AB 918. It involves Imperial Valley Health District's acquisition of the El Centro Regional Medical Center. And the final transaction here is Ascension Health Alliance's acquisition of AmSurge, which I previously discussed AmSurge in one of the previous slides. All right, next slide. Here we have NOR Healthcare Systems acquisition of 6 Los Angeles County hospitals from Prospect Medical Holdings as part of Prospect's Chapter 11 bankruptcy proceedings. Next slide. The first transaction here is Southern California Specialty Care, and that involves Vista Specialty Hospital acquiring Kindred Hospital. The second transaction is UCSF Health's acquisition of Canopy Health from John Muir Medical Group and John Muir Health. Next slide. We've also seen a variety of lab transactions over the past year, so here are 2 of them. One involves Mobile RadX acquiring Hemo Analytics. The other transaction resulted in Quest Diagnostics acquiring 2 Spectra Labs. Next slide. Here we have UCI Health's acquisition of Premier Health Plan Services. The second transaction involves Cambridge Sierra selling the skilled nursing facility in Colton, California. Next slide. Another lab transaction at the top here, that's in LabCorp acquiring BioReference oncology-related clinical testing services. The second transaction is another skilled nursing transaction. This one involves the transfer of operations and real property of the Golden Madera Care Center located in Madera, California. Next slide. Skilled nursing transaction. This one involves Crescent City Skilled Nursing being transferred to a new entity. The second transaction listed on this slide is CCare. CCare is a private oncology practice with facilities throughout California, and we reviewed CCare's proposed agreement to employ certain clinical and non-clinical staff of California Urology. And I believe this is the last slide. Yes. So this one, we're ending on a skilled nursing transaction. This one involves the transfer of a skilled nursing facility from West Coast Hospitals to Laser Holdings. And all of the transactions from the previous 8 slides are transactions that we've waived from a cost and market impact review in case I didn't previously make that clear. And that's the end of it. Any questions?
David?
Yeah, thanks for this. Brian, I'm just curious, do you publish anything around your rationale for declining to pursue or not, because it might be useful for market participants to understand how CMI looks at transactions and which areas will be concerns and which might be not concerns.
Well, we currently don't publish anything beyond the notices that are provided to us. When we waive a transaction, we update the website to show that the transaction is waived, and we're not currently explaining the rationale, although your feedback is helpful.
Yeah, I think, I know you likely can't do it by transaction, but if I don't know, on an annual basis, CMI was to do a report on these are the kinds of transactions we waived and here's why, and these ones we had concerns about and here's why, it might be helpful for the industry to have a better roadmap.
Thank you. That's helpful.
Thank you. Hector?
Yeah, thanks, Brian. Just curious, how are you tracking after transaction costs? Very rarely do we see a merger or acquisition result in lower costs for the consumer. And that's always a concern. And so that's one is, the after the transaction cost. And then secondly, even though some of these are not huge organizations, they're starting to get a footprint in a broader geography of the state of California. And pretty soon, you can get to that point, which the supplemental documents we got on the hospital sector, you get to a point where there's enough of a footprint statewide that that entity becomes a must-have for health plans, which means that the health plans have to pay more, which means the consumer ends up paying more. So 2 things, how do you track post-transaction costs? And then 2, are you looking ahead and saying, are we creating a broad footprint that doesn't seem big right now, but may become a sort of a major driver of costs in the future? Thanks.
So regarding your first question, there's no continuous reporting obligation by any of our submitting entities to kind of tell us how costs are changing, but our team is very active in monitoring the market, not only for the transactions that are upcoming, but with also with transactions that we've previously reviewed. So to the extent we can determine whether costs are impacted, it's definitely something we look at, but that's not something that's necessarily contemplated in our regulations. And regarding your second question, if I understand it correctly, I think in terms of determining how an entity or a transaction is going to impact a healthcare entity's bargaining leverage, I guess, when it comes to payers, that's a key factor that we consider during the course of our review in the pre-CMIR decision, and of course, once the CMIR occurs, it's a factor we consider.
Thank you, Joan. Sorry.
Yeah, we also have a requirement in our filing to give a history of prior transactions. I think it's 10-year look.
Yeah, I don't recall the exact amount, but there are parts in the notice where the entities need to describe previous transactions and then transactions that they're contemplating on doing going forward.
That way we could get a transparency on serial transactions.
Thank you. Joe?
Thank you.
That's actually perfect. I was wondering if there was any update on serial transactions, and if we're starting to see any. I haven't noticed any entities that have been involved in multiple transactions, but just how you're thinking about tracking the serial transactions, and then also about a year from now, would love to. At that point, I feel like we'd start to have enough data to really be able to dig in on more statistics on geographically where are we seeing transactions occur, what types of acquiring entities, what types of selling entities. With only 2 years worth of data, it feels like it's not enough. But by about a year from now, I'd love to be able to get in more on some of those questions of how are the transactions we are seeing changing the landscape of California healthcare.
Yeah, that's very helpful. Regarding that question, I think reporting is definitely something we're talking about. But like you said, we don't have a lot of data. But our program exists to provide public transparency. So once we have sufficient data, I think we're thinking about, okay, what does reporting look like? How can we use the data we've obtained to better inform the public on how these transactions are impacting the public? Regarding your first question, repeat players or entities that we're seeing have larger market shares or are involved in multiple transactions. There's not a ton of data on that just yet. We're seeing more repeat players in the skilled nursing transactions. We're seeing a number of transactions from AmSurge, as I kind of detailed through the slides, but right now that's kind of what we're seeing for the most part.
Thank you. Adam?
Just quickly, thank you so much for the info. What degree of these would you consider a private equity acquisition or, under some definition of that, looking forward? Kind of be your point about, predatory PE acquisitions, dismantling, driving up costs. What percentage of these would be under that, PE guys that we are so interested in?
So there is private equity involvement in a number of our transactions. I wouldn't want to venture to guess like what percentage that might be, but there are a few that definitely have private equities as a party to the transaction or involved in the ownership structure of some of the healthcare entities that are involved. But one of the things that Vishal mentioned in the executive update are our AB 1415 regulations, and that's going to actually require private equity companies and hedge funds and MSOs to provide us with notices of their involvement in transactions as we specify in regulation. So we'll definitely start to see more submissions and notices from private equity this year, and we hopefully will get a better picture of what that looks like.
All right, I think that concludes discussion on this item. Brian, thank you for moving us through that. That will take us to public comment on this item. If you'd like to make a comment, please step to the podium. If you're attending virtually, please raise your hand. Please keep your comments to 2 minutes or less. And to this agenda item, we will have a general comment period at the end of the meeting. Seeing no one at the podium and no hands raised, I'll give it just a moment. That should take us to lunch, and we will return at 1:45. We will take a full hour lunch. Thank you. All right, let's reconvene. And I know we've had some folks join us for the afternoon, so we will do an afternoon roll call. Please make sure to speak into the microphone. I'll start. Joan Allen.
Present.
Barry Arbuckle.
Present.
Katie Bassler.
Present.
Stephanie Klein. Carmen Comsty.
Present.
Adam Daughtery. Hector Flores.
Here.
Stacy Haratas. Iftikhar Hussain. David Joyner.
Present.
Travis Lakey.
Present.
Sam Ma. Amanda McAllister Wallner. Carolyn Nava.
Present.
Mike O'Day. Janice O'Malley,
Present.
Mariel Riazza, Sumana Reddy,
Present.
Christina Rodriguez, Karen Savage Sangwan, Andrew C.,
Present.
Manan Shah,
Present.
Stephen Shortell,
Present.
Sarah Sorokin,
Present.
Ken Stewart,
Present.
Suzanne Usage,
Present.
and Michael Weiss.
Present.
Thank you all. Now we have a record for the afternoon attendance. Our next item on the agenda will be spending target enforcement, waiver of enforcement, technical assistance, public testimony, and performance improvement plans. I will turn it over to Vishal.
Thanks, Jane. We'll be sharing information on the topic of spending target enforcement. So this is distinct from what we covered last time, which was data submission enforcement. So I'm going to go over, I know this process flow looks very convoluted, but I'll go over it step by step. So I'll start with, and then in later slides, we'll be discussing other topics like assessing performance, enforcement considerations, technical assistance, public testimony, and performance improvement plans. We'll begin discussions about penalties in the coming months. So if we start at the first box, which says data submitted and analyzed, this is where entities submit their data in early September, and OCA analyzes the data to determine if the targets are exceeded. Next, we have a decision diamond asking if the target was exceeded. If it was not, the enforcement process of that spending year ends for the entity. If it was exceeded, then we proceed to the third box where OCA notifies the entity that they exceeded the target, and the entity is provided 45 days to provide the office additional information. If the additional information results in the entity meeting the target, so this could be something, whether we got the data right, and then the enforcement of then that means that the enforcement of that spending year ends for the entity. If it doesn't, then we proceed to the next decision diamond, which is step 5, where OCA assesses performance and applies enforcement considerations. And then I'm moving to step 6, which is that all entities will receive technical assistance. Then we get to, and I'll be going over what that means in a few slides. Then we get to another decision diamond where OCA has to decide whether to proceed with progressive enforcement. If we decide not to, the enforcement process ends for that entity. If we proceed, then we go to step 8, which is optional public testimony. And then we'll get into a little bit more detail about what we mean by optional. And then again, we have a decision about whether to proceed with progressive enforcement after this step about optional public testimony. If we do, the next step is to notify the entity of the requirement to develop and submit a performance improvement plan. Once OCA has a plan, it has to be presented to the board for input. And then OCA would approve the PIP and then monitor the entity for compliance with the PIP. In step 13, the entity implements the PIP and provides regular updates to OCA. If OCA determines modifications are required, OCA could require them during implementation of the PIP. In step 14, we have another decision diamond where after the implementation of the PIP period ends, OCA determines if the entity has complied with their PIP. If the entity did not comply with the PIP, OCA can assess penalties or require modifications to the PIP. If they did not comply with the PIP, or if they did comply with the PIP, excuse me, we next determine if the entity met the spending target. If they did, the enforcement of that spending year, the enforcement of that particular performance year for the entity ends. If they did not meet the target per statute, OCA could require modifications to the PIP until the entity has met the target. Okay, so I'll take us to our next slide. Now we'll go through some of the spending target enforcement topics individually, beginning with a waiver of enforcement. So we'll start with what the statute says about waivers. First, we have the requirement that OCA gives entities 45 days to provide additional information. When we provide them a notice that they've exceeded the target, and that information can be used, gleaned from that 45-day period to support a waiver, which is described in subdivision I on this slide. OCA may establish requirements for a waiver, and the statute lists reasonable factors outside of the entity's control, anticipated costs for investments and initiatives, or extraordinary circumstances that can be used to determine whether a waiver is appropriate. Next slide. So next I want to discuss the difference between some terminology. So on the left we have what we're referring to as enforcement considerations, and we went over several of these last advisory committee meetings. So these refer to factors that OCA can consider during enforcement. This comes from a specific part of the statute which describes what the director shall consider during enforcement. They include these 4 bullets listed here. Each entity's contribution to cost growth in excess of the applicable target, any actions by the entity that have eroded or are likely to erode access, quality, equity, or workforce stability, factors that contribute to spending in excess of the applicable target, and the extent to which the entity has control over the applicable components of its target. And then moving over to the right side of the table is reasonable factors. So this is from a specific part of the statute which describes an optional waiver process which OCA may establish. Reasons that would allow an entity to apply for a waiver include the 3 that I've mentioned before listed as these bullets. And then we're distinguishing between the 2 because the distinction is important for the next few slides. The 2 terms, enforcement considerations and reasonable factors. This slide shows a list of potential enforcement considerations. So we went over these one by one in the last advisory committee meeting. Excuse me. These are characteristics, spending attributes, or other circumstances that OCA could consider when determining which entities would proceed beyond technical assistance to public testimony, performance improvement plans, and/or financial penalties for a given year. So these considerations don't change or modify an entity's reported performance or directly exempt or waive from enforcement each year. These considerations will be explored for their validity with in-depth conversations with entities and for them to submit supporting evidence that could be evaluated by the office. These considerations will likely not impact all entities uniformly, and in many cases cannot be forecasted and incorporated into the process of setting targets. If the office notices consistent trends or effects across entities, we could present this to the board to inform prospective adjustments to the targets. I'll take us to our next slide. And then actually, if we could go back this one, then last point I want to make is that, these enforcement considerations are still being publicly discussed. And, you know, we would promulgate some draft regulations later this year with more information about kind of what makes it into the regs. Next slide. So we want to update the advisory committee that OCA will not implement a waiver of enforcement at this time for healthcare entities who fail to meet the target. And some of the reasoning for this is that the list of factors under the waiver are duplicative with the factors that OCA can consider under enforcement considerations. So as part of the process to assess an entity's performance against a target and determine which entities may proceed along the process of enforcement, OCA can assess reasonable factors, anticipated costs for investments and initiatives, and extraordinary circumstances. After we have some program experience of measuring, reporting, and enforcing targets, we can revisit this issue of kind of what specific conditions or circumstances may warrant a waiver. So it's something we could definitely reassess later. And then I'll go over technical assistance that I mentioned earlier. So we begin with some of the statutory language focused on technical assistance. OCA's statute says the director shall enforce the targets and may take progressive enforcement actions, including providing technical assistance to help entities come into compliance. The statute also says when an entity exceeds a target, the office shall notify the entity of their status and provide technical assistance. It lays out some process requirements, such as giving the entity 45 days to respond to notification of their status, and then for them to provide OCA additional data and information. The statute also says we need to consult with sibling state departments, including the Director of Department of Managed Healthcare, the Director of Department of Healthcare Services, or the Insurance Commissioner, as applicable, prior to taking enforcement actions. So this consultation is specific to payers. And then lastly, statute also says that OCA shall provide entities that exceed the target with technical assistance. So all entities will receive technical assistance. So we want to share some information about what we mean by technical assistance. Technical assistance under progressive enforcement of spending targets is information provided to healthcare entities to support their capacity to meet targets. This technical assistance will be a letter to the entity who exceeded the target, providing them with resources they could employ to assist with coming into compliance with the targets. These resources may include research studies, literature, information such as models for increasing primary care investment and APM adoption, and cost-reducing strategies that have been presented to the board and this committee. Letters may be tailored by a healthcare entity and may decompose areas of excess spending. So for example, we could send a tailored letter that includes total medical expense, descriptive statistics highlighting kind of where spending is growing fastest. And then technical assistance does not mean OCA will direct an entity to implement specific changes to their operations. I also want to note that technical assistance is distinct from performance improvement plans, which we'll talk about later in this presentation. So we want to pause now for any questions from the committee about how we're defining TA or the waiver process or enforcement considerations that I discussed earlier.
Go ahead, Stephen.
Just a brief, addition to resources potentially would be a list maybe of technical assistance organizations or consultants that are well known up and down the state could be provided to them. And then also there's a number of quality improvement collaboratives that exist up and down the state and through some of the provider associations and so on that could be made available also.
Thank you. Hector and then Andrew.
Thank you.
Hector.
Yeah, thank you. Just a couple questions. It's been mentioned in the past, technology costs are pretty expensive. I didn't see it on the earlier slide with the different categories, so maybe it's embedded in those. But definitely, as organizations move to explore the use of artificial intelligence, what we're starting to see is very costly investments that they'll have to make with products that are not quite yet proven. So it's something to also keep in mind that along with EMR and HIE and remote patient monitoring, telehealth, et cetera, that we include the artificial intelligence investments that are going to be made. And then the second part on the technical assistance, so it sounds like OCA will provide suggestions, but it will be up to the entity to take those under consideration, and to Steve Shortell's point, engage a consultant to help them kind of work through if it turns out that that's what they need to do. So that's another expense that should be taken into account, because these types of organizations not only come in to do an assessment, but really to be effective, they need to stay on the campus and make that implementation of their strategy come to fruition. So those are things to keep in mind as well.
Thank you. Andrew and then Michael.
Yeah, I'm just thinking about the number of organizations that are subject to the target and may exceed it the first year. You could have hundreds, right? So I guess the technical assistance, how tailored will it be to the organization, or is it really a list of resources? I'm just thinking about volume, right? As we go through kind of all of the pieces here, that first year, that first 3.5, signs are that a lot of people will exceed that.
Yeah, that's something we're thinking about, and it would be, a minimum different by type of healthcare entity, like payers, like plans would have a specific letter versus physician orgs and hospitals. But is a suggestion to have kind of more granularity in terms of different types of hospitals and different types of plans even?
Well, I guess that's kind of where, what do you mean by technical assistance? I mean, I don't want to sound, this is not going to sound great, right? So it's, is it like basically a form letter for, health plans, hospitals, and medical groups, and say, here are potential resources for you to actually tackle, or is it going to be more specific to, you exceeded your target because of this, and then there are these resources for that. So I'm just trying to figure out.
Yeah, it depends. And it kind of depends on the granularity of the data we receive as well. So for plans, we do get that service category breakout. We get a regional breakout through our direct data collection. So we're able to say it looks like, inpatient spending and prescription drugs and professional services are all these look like the ones that are influencing your overall target being exceeded. So with plans, we may be able to do that with a little more detail. But for the other the other provider types, we're still kind of assessing what's the level of detail we could provide in a TA letter.
I think, Vishal, what I heard you say is you're going to do free consulting for the plans.
So this, I want to be clear that it's not OCA providing consulting services. It is kind of a more generalized set of resources. It's the PIP would be far more specific, and that's where the entity. We'll get to that later, but that's where the entity would propose specific strategies.
Thank you, Michael, and then David.
Yeah, my question is about the disallowance of waivers at this time. I guess I'm I'm hesitant because of the extreme volatility in our industry right now and the uncertainties. I think if ever, now is the time where we're going to see a lot of these things happening. And I'm just curious about whether this is the right time to not allow that or to reconsider that in some way, especially for safety net organizations that are at the whim of some federal funding that may or may not come.
Yeah, yeah. Thank you, Michael. As we stated, there's the things we could consider under the waiver. There's 3 examples given in statute about the reasonable factors, extraordinary circumstances, and investments, and those are just illustrative examples because it's a such as language. So you could either define a bunch of factors under a waiver process, or you could do it under what we're calling enforcement consideration. So we found those two to be duplicative. And if we were to simultaneously have a waiver process at the same time as this other enforcement considerations, it may cause some confusion. We always kind of reserve the right of revisiting it, and as we learn through experience, like we may very well learn something about a particular class of entities, and then we may need to have a waiver process in the future.
David and Carmen, and then Tam. And
Vishal, I'm curious, and suppose you have a hospital who has seven hospitals in their portfolio, and as a system, they make the target, but like 3 of their hospitals are above the target. Same scenario could be a health plan who overall meets the target, but maybe some lines of business are above the 3.5%. How are you going to approach that? In that situation, does that hospital or health plan meet the target if they meet it overall, or just the fact that they have some components that don't? Do those get an enforcement letter in this scenario?
Yeah. So at this time, we're not measuring systems. So it all kind of boils down to our statute defining healthcare entities a particular way. So we would measure each hospital, each facility, and then through the HCI filings, we know who those entities are, and we would measure them. We'll likely be aware, like, these are the Adventist hospitals, these are the Dignity hospitals. They may have, there's going to be variation. Some of them are going to meet it, some of them are not. So we're not doing any system roll-ups at this point. And then for plans, and this is kind of for other types of entities too, that we would want to enforce the target by market. So by your commercial line of business, your Medicare and Medi-Cal.
Use the microphone.
We intend to do it by line of business.
So we've got Carmen, Tam, and Amanda.
I had just a clarifying question here. When we're talking about progressive enforcement, and I see the flow chart goes from technical assistance, public testimony, PIP, and then penalties, administrative penalties. What is the time frame, like, if you were taking it step by step? Is that the idea, or, particularly with technical assistance, if it's really like a letter with identifying different types of technical assistance that can be, that an entity can use and implement, are you going to wait until implementation has occurred and then move to the next step of compelling public testimony, or what is the actual time rate between each of the steps, or potentially could some of these happen all at the same time?
No, we wouldn't wait. It's a requirement that they receive technical assistance. For some of them, some entities, depending on OCA's, the way we prioritize which entities to enforce the or take them further down the progressive enforcement process. Some may just receive technical assistance and the letter, and that's it for that year. And then, we'll see them how they perform the following year. And then some may, we want to take them beyond TA. and that's going to be a fact-specific circumstance. So we may compel them to do public testimony, or we may move them along to a PIP. And we wouldn't wait until like the next year.
Tim?
Just going to slide 86, I think it is, on the potential enforcement considerations. So can you say again the office's plans? Because I think I heard you mention that we may be promulgating regulations later this year. So are those what are those regulations intended to cover?
Yeah, the regs would cover the gamut of the enforcement process. So TA and kind of what that means. Information about public testimony if that's something that we include in the regs. And then these enforcement considerations would need to be enumerated in regs.
And so is the list that's on slide 86 on the potential enforcement considerations, those are just preliminary ideas, and that is the office open to suggestions or feedback on additional considerations that could be taken into account, and that would then be incorporated into the reg process?
Yes.
Okay. And then when do you expect to begin that process?
I think we might have a timeline slide later, but we could circle back on that later. Yeah, we'll get to it. Yeah, we'll come back.
Amanda?
Hey there. Good afternoon. Amanda McAllister-Wellner, Health Access, California. We support the staff recommendation not to rely on waivers of enforcement at this time. I think the staff has, shown its due diligence in, carefully considering the enforcement considerations, and I think giving an opportunity to really take instances on a case-by-case basis, and really thoughtfully consider the reasons that the target may not have been met. What were those considerations? I think is the right approach, and grateful for the work that staff has done to get to that point. And we do think that, like, while there may be outlying examples of when a waiver may be appropriate, the first few months of a global pandemic, for instance, most other examples, really do feel more appropriate for the enforcement considerations. On the enforcement considerations on page 86, I know I'm probably going to sound like a broken record, but just want to really emphasize that not every one of these in every instance will be is something that's outside of an entity's control. For instance, high-cost drugs may at first glance seem like an issue that's outside of an entity's control, that is maybe driving up costs and causing the target to not be met. But upon further inspection, we actually oftentimes see that that covered entities are charging 2, 3, 5 times the Medicare rates for these drugs, or the and actually using some of these high-cost drugs as a major profit driver and profit center within those systems. And so, really taking these on a case-by-case basis, I think we have a great deal of faith in the staff so far, has shown a lot of consideration and understanding of how of the nuances of, for instance, high-cost drugs within operate within these entities, and that there's not kind of a single approach. But just want to emphasize that even within the potential enforcement considerations that are listed here, that we should really be taking a pretty nuanced approach to making sure that that those things are actually outside of the entity's control and not something that we should be pushing for entities to control in order to meet the cost growth target.
Joe?
Thinking about the list of considerations that must be included in terms of that erosion or likely to erode access, quality, equity, and workforce stability that's listed there on slide 85. And so much of this conversation will be a conversation between the entity and the department. But in terms of those factors, there are likely to be external stakeholders who are in the best position to have insight into those potential erosions. And so looking through that lens at the workflow diagram, can you talk a little bit about where the public is brought into this process, whether it is the entire public or relevant stakeholders? I know there is the conduct public testimony optional. Where else in the process would, for example, the labor union representing the workers at the hospital, or the board of supervisors in the county, or other entities that would have information and a say in that process as to whether a performance improvement plan or earlier in the process the failure to meet the target. Just can you talk through where other stakeholders are brought in?
Thanks, Joan. Yeah, this is something we could take back, but at least an initial kind of thought on this is that we do need to post the identity of entities that exceed the target. That doesn't necessarily mean we're going to enforce the target on them, but that could be a way for the public, and including groups with relevant information about the part of the statute you reference, to make a public comment or bring it to the attention of OCA.
Yeah, that's really helpful, and just thinking through how to create the process for stakeholders to actually be treated as stakeholders, and that would be really helpful.
Thank you. David?
I know that one of the reasons why in particular hospital costs might go up substantially is a new union contract that increases the cost of labor substantially. And I don't see that in the enforcement considerations list. Okay, can you explain how that fits as you think about it?
So I think it's an entire topic for another day around organized labor adjustments. And so I think we'll be coming back to this AC and having a much more in-depth discussion around organized labor costs and how that can get factored into adjustments to the target itself.
When you do that on another day, I would really appreciate if you'd address the issue of, to me, there could be an inequity where a hospital that doesn't have labor representation might end up being actually discriminated against because they don't have the ability to have that out clause that you just mentioned. I'd appreciate if you could include that in the agenda.
All right, it looks like that concludes discussion on this portion. Yep.
Yeah, while we're on the conversation about the adjustments for organized labor costs, I think I really encourage that we have that conversation sooner rather than later. I think the statute does make it very clear that the board is required to adjust the targets to account for those costs. For 2025 was an enforcement year, but it is reportable. 2026 is the first enforceable year. And so I think for those of us that are impacted, we're very eager to learn about what the process will be for requesting those adjustments, what all needs to be submitted to the office for that process to happen.
We've got Adam and then Barry.
So similar to Joan's points, specifically to the technical assistance definition, I do hope there's an opportunity for stakeholder input on any of these cost reducing strategies, both for our own healthcare entities, but also for others. There's, of course, when we get there, there's going to be lots of finger pointing. There's going to be lots of, picking winners and losers here, depending on what evidence or suggestions you provide and what is actually undertaken. And I do fear that, the easiest way to do this is going to be to cut services and limit access. And I think that's, should continue to concern us. On those cost reducing strategies, you can go down the rabbit hole of, any union contract, any, profit motive, any, shareholder, primary incentive to, abuse of overtime, abuse of FMLA. You could go down the list of how these entities operate as a business and whether they're doing it well or not. So, I think it's going to be difficult if you're going to do it piece by piece, then it's going to have downstream effects to the other healthcare entities. So, we all have, I think, our unique lenses and experiences with having to deal with whether it's payers or systems or, other groups. So I think it, behooves us to, in the effort of transparency, have all those strategies collected and have it in a public way that we can all look at, access, and be able to respond to based on, accuracy and actual effectiveness. So.
Thank you. Barry and then Sarah.
And just to comment on the topic that David and Tam raised, when we bring that discussion, CJ, back to the board, I'll repeat what I've already said twice in these meetings over the last 3 years, and that is that the not exception, but the consideration of a recent union contract should not only apply to the unionized entity. That would pretend that employees aren't pulled from the same job market. I have, within my company, I've got 2 hospitals in South LA County that are unionized, 2 hospitals in Orange County that are not. They pull from the same market. So when Long Beach Memorial has a big increase, my Orange County hospitals have to follow suit. When Kaiser does a big increase, they're right down the street, we have to follow suit on the non-unionized hospitals. So that's got to, we need to factor that in some manner or form. So.
Sarah?
I was thinking that maybe we need to take a look at whether a unionized workforce in the end does cost an entity more money in terms of if a workforce is unionized, they likely have better pay, likely have more stability in terms of less turnover, a higher quality of care, things that may actually improve quality and reduce costs. And that also got me thinking about what if entities meet the target but show poor quality, and maybe that's outside of what this body is tasked with. But I'm thinking, and I have no idea what my employer, if they would meet the target or not, but at this moment, we're under a corrective action plan with Partnership Health Plan because of lack of timeliness in child visits and other primary care services. And I know, it's important, like Joan said earlier, to have stakeholders who would have information that's important to really fill in the picture, because I think what you would hear from my employer is that we are having a hard time getting staff, and that's why this is happening. Where there's reasons why that are modifiable by the entity. They could solve that issue by, changing working conditions or pay, or, but yeah, just wanted to add those 2 comments.
Travis?
There we go. I had some questions on the process, how interactive it would be. Is it all just official letters, or is this things where you can call the office and discuss it, or is it all just very formalized letters back and forth?
Yeah, we're still working on the details for that. we would need to have some systematic way of engaging with entities, whether it's some type of portal. But we're thinking through kind of how that could work. But it would include meetings where we engage with the entity directly.
Oh, perfect.
All right, we'll continue the presentation.
All right, so next we will discuss public testimony. Go to the next slide and quick overview of the statute. Essentially, as we know, the OCA statute directs the director to enforce the spending targets and take progressive enforcement actions, including requiring or compelling public testimony by the healthcare entity regarding its failure to comply with the target. Go to the next slide. So I'll share some information on how OCA is defining public testimony. Public testimony is an optional step in the progressive enforcement process and at the discretion of the director. Public testimony is an opportunity to hear from healthcare entities that have exceeded the spending target. It can take various forms, including in-person or written testimony. Entities may elaborate on why they went over the spending target. Public testimony for spending target enforcement is not an invitation for entities who are meeting the spending target to explain why they are doing so. We can invite these entities to our meetings, but they are not required to comply. Asking entities to explain how they plan to meet the spending target in the future. Next slide. So again, we're looking for discussion and feedback from the advisory committee. Under what circumstances would the advisory committee want to hear from healthcare entities regarding exceeding the target?
Discussion, Amanda?
Thanks. I would say under all circumstances, I would like to hear from the healthcare entities regarding exceeding the target. You know, I think especially as we start out, you know, we don't know what we don't know. And having maximum transparency, having maximum public participation in the process will help all of us, I think, best understand what's happening with the cost growth target, what's happening with compliance, where, you know, where can we improve and refine this process. And I'm sure each of us has an interest in really understanding the evolution of this work and enforcement, and also, you know, understanding any reasons that, you know, staff may be considering changes if we don't have information about, you know, what's actually happening as it happens. I think we're going to be playing a lot of catch up with regard to kind of like why some things, you know, why things are moving in certain directions. And so I would say under all circumstances at every, you know, at every step of the process, you know, as soon as that data is submitted that shows that an entity has exceeded the cost growth target, I think it would be appropriate to make it public and for the advisory committee to be notified.
Katie, Andrew, Carolyn, Janice.
Yeah, so I guess I'm back to volume of potential entities exceeding the target. You know, I mean, we're going to be here a lot if we're going to do, you know, a lot of entities exceeding the target. So I guess to me, we probably have to think through outlier criteria, at least in the beginning, right? Similar to, you know, what the staff did on the hospital, kind of outlier hospitals. It just, we don't know what we don't know, right? If there are 400 entities that exceed it, we're going to be here every day. And I'm not sure that's the intent of it. So one man's opinion.
Katie, Carolyn, Janice, and Michael. Katie?
So I want to echo what Amanda and Andrew said. I do think full transparency, as much information as we can so that the system can be adjusted. I understand the workload, but I also have so much trust in staff to be able to develop some kind of platform that's going to identify common factors that then we as an advisory board can look at. But I do think full transparency is how we get better and entities get better. Thank you.
Thank you, Carolyn.
Thank you. I
concur with Amanda as well as Katie. And while I respect that this can be an information overload, I think it's important for those on the committee who desire to understand and know as much as possible to have access to that. I've been at this table for about 3 years now, and it seems like more often than not, it's a waiver of everything that's out there. And I'm thinking, how do we get to that point where everything gets waived? And are we catching this somewhere down the line, right? Because if we're looking at large operations merging together and everything gets waived, how do we see the impact from this side of the table to give appropriate input down the road? So I'm all about information. I'm not the smartest one, and I don't have all the letters behind my name, which is why I appreciate the information. And I'm hearing that others kind of feel that way too. So for me, the more the merrier.
Thank you. Janice, Michael, and Carmen.
Yeah, just echoing Amanda, Katie, and Caroline's point that I think more transparency, the better. And I do hope that these entities don't brazenly go over these cost targets. But have you thought of a reason why the director would choose not to have a public hearing?
Yeah, there's a variety of reasons. Some could include, you're giving a platform for the entity to essentially come and like more kind of marketing, kind of like promoting themselves, and you may not get kind of the particular root causes as much. Because it is a public setting and kind of, people may, or healthcare entities may kind of have a different intention going into those public testimonies. And then there's also kind of, you could also obtain the information in a written format rather than, having them come in. So there could be a variety of reasons.
So do you think that these entities who exceed the targets would come in and give a glowing report of why they've exceeded the target because they've done all these amazing things and they've given raises to all of their employees? And
that could be one.
Okay. Okay. Again, I just like to reiterate, like, more transparency, the better. If there are entities that are doing all those amazing things, then maybe it's worth looking at them, and but I'd be shocked if that were the case.
Thank you.
It is intended to be like it is their testimonies, and they should address the questions, but and then the board would have an opportunity to have the back and forth, but it kind of depends on like if you could obtain the information in another way through written communications, like just something to consider.
Michael, Carmen, Carolyn.
Yeah, I also support the transparency. I think it's good. I would actually look at it as a really tremendous opportunity for us to learn. I think I'm echoing a little bit of what Janice said, which is we may hear some things from these entities that we never thought of. You've got a lot of smart people here representing a broad stakeholder group, but not everybody. And it might be an interesting opportunity to learn as well. But I would also suggest if it's not described elsewhere in statute, and it may be because we can't put everything in slides, that we create a template for what their testimony is to include, and maybe include things where we would ask questions, the questions that we want to get an answer to when they testify, so that we can learn.
Carmen?
Yeah, I had a kind of similar question, which is, agree with other folks saying more information is better. Trying to figure out what exactly the form of public testimony is. Are we thinking something like what Joan was talking about earlier, which is, is this somewhere where we're going to try to incorporate stakeholder feedback, or is it something where it's OCA
asking questions to the entity, or is it just going to be one way and an entity providing information to OCA without kind of questions, or or are you even thinking of something like that's something different than a hearing or meeting?
So it would be the board engaging with the healthcare entity. Members of the public could certainly make public comment afterwards, but it wouldn't be like members of the public directly asking the healthcare entity questions.
Thank you, Vishan. This is really helpful, and I wanted to just bring consideration back to slide 86 with those potential enforcement considerations, because I think some of those topics, looking at this from a rural lens, which I'm in a rural frontier region and I live in Paradise, California. We all know what that means, right? So when I look at the loss of FQHCs in the region, when I look at the fact that we've lost Medicare Advantage in some of our counties and the lack of primary care providers, the closure of small county hospitals, that's all hit us post-disaster. And there are a multitude of reasons where any of these entities could come forward and be looking at, like we said, stepping outside the boundaries, because it's unexplainable costs post-disaster, but that flows down to the everyday person in a multitude of ways, because they no longer have access to services without driving 3 or 4 hours. You no longer have insurance that's covering what they require to have done for their family member or for themselves. And so if there's not some sort of reverberation and feedback to clearly understand why they're outside of the boundaries, how do we justify that when it gets down to the consumer who's saying, I'm still paying all this money and I have no services? What are we doing?
Thank you. Andrew, and then I think we'll continue on.
Yeah, so just quick question. Will the submissions from the various entities be made public? Like, people miss the target, they're supposed to give some kind of justification. I'm just trying to think through, is there some, written, publicly available document that's going to be available, and, then staff will do some analysis around it and, invite people to speak. I'm just trying to think through. Again, I'm in the volume, there are hundreds of entities here.
That's a good question. So we'll take that one back, because there's kind of confidentiality provisions in the OCA statute for certain things. And then there's also general California law, trade secret law. So there's kind of different ways that confidentiality could be maintained. And we could have some slides laying that out next time.
All right, Joan, and then we'll wrap.
I really appreciate that, and would encourage you to be as biased toward transparency as the law allows, especially as we are standing this up. It is incredibly valuable for stakeholders across the state to be able to understand how entities are thinking about their relationship to the target. And so making sure that as you're figuring out what that submission looks like, making sure that there is a version of it that can be made public. And we have good experience so far with the CMIR process, where there's that mix of public and private, and just would encourage not to immediately go toward trade secret, but instead also go towards the public's right and interest in knowing.
All right, thank you. Continue on.
Sure. Thanks. So we're now going to introduce information about performance improvement plans. We're going to start with how PIPs are done in Massachusetts and Oregon. This slide gives an overview of Performance Improvement Plan, or PIP, regulations in Massachusetts. The Health Policy Commission, or HPC, as is referred to in the state, may require a PIP if an entity exceeds the benchmark, is what they refer to their targets. Entities have 45 days to submit a PIP proposal and may request an extension. Requests of extensions greater than 45 days would require a board vote. Their PIP implementation period must conclude within 18 months. So the PIP needs to address drivers of excess cost growth and meet goals that address the performance year's excessive cost growth, mitigate impact to care, services, access, and then translate into savings for consumers. The HPC monitors entities for compliance with the PIP. They may require entities with unsuccessful PIPs to continue with the existing PIP or submit a new PIP, or they may delay or waive an additional PIP. They may assess a penalty up to $500,000 if an entity willfully neglects to submit a PIP, knowingly fails to provide required information, or does not implement the PIP in good faith. And the HPC has required one PIP so far, which achieved about $200 million in savings. So this slide is a screenshot of a timeline on HPC's website showing the different steps involved in the PIP they completed with Massachusetts General Brigham, or MGB. We added the dates in yellow so you could see how long it took them to get from step 1, where the board voted to require a PIP in January 2022, to step 10, where the board voted to determine the completed PIP a success in December 2024. I want to note in step 4, they had an initial submission in May of 2022. There's quite a bit of back and forth. It was their first time requiring a PIP. So there were revisions, and it eventually was resubmitted in September of that year. Now I'll take us to Oregon's PIP process. So the Oregon Health Authority, or OHA, must require a PIP for entities that exceed cost growth target without a reasonable cause. Entities have 90 days to submit a proposal and may request an extension. PIPs must conclude within 24 consecutive months from the date in which the PIP is approved, unless OHA extends that time frame. PIPs, similar to Massachusetts, need to address the entity's drivers of cost growth, generate savings for members, patients, payers, and purchasers, and then the savings need to be sustained beyond the PIP implementation or performance period. Entities must submit progress reports every 6 months. OHA may require entities with the unsuccessful PIPs to continue with the existing PIP or submit a new one. And then I want to lastly note that the Oregon Health Authority also has a financial penalty option for enforcement. So taking us to the next slide, this shows a screenshot of an example PIP timeline that Oregon created for their PIP guidance document. They estimate for the 2022 to 2023 spending period, a notification of the requirement to complete a PIP could happen in Q2 of 2025. Implementation of the PIP could have begun in Q4 of 2025, and then last through Q3 of 2027, based on those timelines I mentioned earlier. So I'll shift gears to talk about our statute. We do have a requirement, as I mentioned earlier, to consult with departments before taking action on performance improvement plans. The departments listed here are primarily applicable or are applicable to payers. Next slide. So this section of the statute includes the following. OCA may require entities to implement PIPs. They could last up to 3 years. PIPs cannot propose to meet the spending target in ways that are likely to erode access, quality, equity, or workforce stability. OCA has to monitor entities for compliance with the PIP. And then OCA needs to transmit PIPs to other state regulators. And entities shall implement their PIP as approved. So this section of the statute covers legislative intent, and here we see the legislature intended for enforcement to be progressive and for entities to be given an opportunity to come into compliance with the spending targets via technical assistance and performance improvement plans before being assessed penalties, except for specific egregious violations, which will be shown in a later slide. So this slide outlines confidentiality requirements for the board, OCA, and others. Andrew, this is some of the language, but then there's also other California law that we'll go into more detail at a later meeting. And then the next slide, the statute also stipulates that an entity that has fully complied with an approved PIP by the deadline, but has not met the spending target, shall not be assessed administrative penalties. In these cases, OCA could require the entity to modify their PIP and continue with implementation until the target is met. And on this slide, this talks about the previously mentioned egregious violations. So we could directly assess a penalty when an entity repeatedly neglects to file a PIP, repeatedly fails to file an acceptable PIP with the office, repeatedly fails to implement the performance improvement plan. Next slide. So this slide shows different statute excerpts. The annual report has to include a list of PIPs required. The board has to review and provide input on PIPs before OCA approves them for implementation. And the board has authority to hold closed sessions to discuss matters related to requiring PIPs. So this slide shows how OCA is defining performance improvement plans. So PIPs are action steps and strategies a healthcare entity agrees with the office to implement to come into compliance with the spending targets during a specified time period. Entities will include in their PIPs the causes for spending growth, specific strategies, goals, adjustments, and action steps, and propose measurements to track performance improvement. The success of a PIP will depend on entities' compliance with their approved PIP and their performance against spending targets. PIPs, we want to know, are not developed by OCA staff. Entities are responsible for developing a proposed PIP that will be evaluated and approved by OCA. Next slide. So we have a few process steps before we turn it over to questions, but so this is, we're splitting it out into 3 parts: pre-implementation, implementation, and post-implementation. So during the pre-implementation phase, it would include the following steps. OCA would determine if a PIP is required. We would need to consult with the relevant state departments before taking action. The entity would have 45 days to submit a proposal. We could provide them an extension of up to 30 days, and then include a requirement for them to provide the office weekly updates. OCA evaluates the proposal, consults with relevant regulatory agencies, gains the input from the board, and then discusses the proposal with the entity. Then OCA makes a decision to either approve the PIP or require modifications and resubmission of a revised plan. And then moving us along to the implementation phase of the process, the entity begins to implement the PIP. The implementation period must end within 3 years. Entity provides progress reports and meets with OCA staff in accordance with the PIP timeline. OCA evaluates the entity's progress and determines if the entity is complying with the PIP or if the entity must modify the PIP. Significant modifications may require consultations with regulators and input from the board. And then now moving on to the post-implementation phase of the process. After the PIP implementation period ends, the entity has 45 days to submit a final report. OCA evaluates the final report and determines if the PIP was successful. So this is the timeline, projected timeline that I mentioned earlier. You can see that we introduced the topic with the board in July. We also met with the advisory committee in September. So, we'll likely take certain topics to the board first, or to the advisory committee first, depending on the calendar. But the general time frame is listed here. We started off early on discussing assessing performance, technical assistance, public testimony, and performance improvement plans. And then in March and April, we'll discuss penalties. We're aiming for a board vote on the scope and range of penalties in April. That could be subject to change depending on where we're at. And then from May through October, we'll be in the regulations development process. And then as far as the advisory committee, we have the meeting this month, and then we'll see you again in April, June, and September. And then we plan to include, at the April meeting, our goal is to discuss, continuing discussions on enforcement, including penalties. In June, we hope to provide an update on the board's vote on the scope and range of penalties. And in September, we'll share updates on the regulations process. So just want to pause here for any feedback or comments from the advisory committee.
Stephen, Carolyn?
One suggestion might be on the plans that are submitted in the progress reports, whether there'd be advantage in creating a template for them, or at least categories or headings to kind of make it comparable or easier to read. And I'm wondering if Massachusetts or Oregon, for example, may have done that. I don't know if we can get a copy of the MGP one, maybe redacted. Do you have a copy of that just to see what a performance improvement plan looks like in another state?
Yeah, I'm sure if it's not linked in the slides, I'm sure we could circulate it. Yeah, but it is. They do have a public-facing version.
Okay, great. Thank you.
And that is something we'll take back about your comment about a template.
Yeah, just to make, otherwise it could roam all over, et cetera, et cetera. Yeah.
Carolyn, David, Katie?
Thank you, Vishant. Just a quick question. I know on the future board discussion that dates can flux and whatnot, but will this committee in April be afforded opportunity for comment before that proposed April board meeting? Otherwise, it seems like our comments are for naught.
Yeah, that's something we could take back if there's not, if the advisory committee, generally in the past, if the advisory committee didn't proceed a board action or vote, then there's other ways we could solicit through email. Or we could schedule another meeting.
David, Katie, Amanda?
Can you just go back to the timeline for a moment, please? As you're discussing penalties and you're looking at the scope and range, I think it'd be useful to know, at least for the first year, how many providers missed the target, how many health plans missed the target. while I was sitting here, I got an email. My health affairs subscriber, and they just reported the increase in healthcare expenditure in the United States in 2024 was 7.4%. So, you know, I know that's not a California number, but in my mind, I'm imagining a very large number of entities missing the 3.5% metric. And I just think it might be helpful to have a sense for that as you think about penalties. In other words, if you were in Massachusetts, you only had one, you might think differently than if you're in California and you have 200, not missing the deadline, the metric. So where on this schedule would you see the 2025 analysis of entities versus the target for 2025?
We don't have 2025 data yet. We only have data up until we just collected 2023 and 2024 data this past fall. And then in June, we would report on that. So last year, you got us, we presented the baseline report, which covered 2022 to 2023. And then now it's going to advance, one more year. So there's always going to be a lag. We won't get the, in fall of 2026, we're going to get 2024 to 2025 data. And then keep in mind the 2025 target's not enforceable.
Yeah.
It's just a reporting year. It's on a different timeline than this. And then.
So I understand 25 is not enforceable, but my 2 cents, my advice would be I wouldn't decide penalties until you saw your first big report of your first non-penalty metrics, because I think it might inform how you would set penalties, would be my advice.
Thank you.
Right now, if you're going to cite these before you've ever seen the first report, which to me seems a bit backwards.
Katie?
You had me thinking. That's not what I was going to talk about. I was going to build off of Stephen's comment about a template from Boston or excuse me, Massachusetts or Oregon. I see their timeline as being very extended, about a 2-year period in order to address their PIP. Is there a timeline on there? It'd be interesting to see. That seems a very elongated time period to make adjustments when entities have had advance notice that there is this target. So I think seeing that template would be interesting to see. So thank you.
Amanda?
Similar comment. So, I think looking at the timelines from the timeline that you shared for California, the timelines from Oregon and Massachusetts, we OCA will learn that an entity exceeded the cost growth target 2 years after they exceed the cost growth target, put a PIP into place, and then 2 years from then we'll know, there's it's inherently a long process. And I think the more that we can build in transparency checkpoints along the way, have milestones along the way, so that we're not, so that we don't have any clue whether performance has improved, for 2 years, right? I think the anything that we can do to, assess the effectiveness of the PIP as it goes along will be helpful, because otherwise, we won't actually know if any PIP was successful until 2030, and I think it just it's a lot of data, it's a lot of it's a complicated system, and I don't want to I don't want to seem like I'm saying it's easy to figure out how to do this. I understand that the measurement takes time, is complicated, And, and especially when you're trying to measure that change over time and that change in performance. And also I do think that, finding ways to do that over time and to also bring it back to the advisory committee and the board throughout that process is important. I do also want to mention there on slide 105, going back to the statute, I think is always helpful. And it references topic of previous conversation on what data is considered private. And I think it really does, illuminate that, that any information that is otherwise publicly available or that's not been confidentially maintained by the source shall not be considered non-public information. And it even gives the office discretion to share non-public information when it's in the interest of the public and when it's when it's appropriate to do so. And so I think again it just underscores the intent for there to be transparency throughout this process. And I think that the length of this process, the complexity of this process also, reinforces the need to really have transparency throughout and to have the ability to measure as we go along.
And I mean, to that point, in the effort of teamwork, and we're all kind of in this together, I think it would be a responsibility to identify some of those restrictions to whether through legislative process or regulatory otherwise, to be more transparent in how these businesses use taxpayer dollars. Sure, it's proprietary information, but it's our money. So why can't we be more proactive with recommendations in that regard, and then also in deregulation of a lot of this arbitrary, very, very expensive process that we've created in this state. I think on both those fronts, it would behoove us to really defend a lot of these entities in a way that creates progress and spending money smarter.
All right, I think that concludes discussion on this portion. Are we towards the end? A little more. All right. We'll now move to public comment on this agenda item. Please step to the podium. If you're online, please raise your hand. Please limit your comments to this item and to 2 minutes if possible. Looking to the podium, seeing no one at the podium, seeing no hands raised, we'll give it just a moment. All right, we will move to our final substantive agenda item, Introduction to the HCI Health and Primary Care in California Snapshot. I'll turn it over to Margaretta Brandt.
Thank you. As we get settled. So hi again. Yeah. For this agenda item, Debbie and I are excited to introduce to you all a new initiative at HCI that is facilitated by OCA, which is the HCI Health of Primary Care in California Snapshot. And in this presentation, we'll provide some context about the Primary Care Snapshot Initiative, the project team, and our planned deliverables. And then we'll wrap up with an overview of our upcoming snapshot brief and some next steps for the coming year. In the next slide, I'm sure many of you are familiar with this context, but I just wanted to kind of lay the background for why we are pursuing a snapshot, primary care snapshot in California. So the National Academies of Science, Engineering, or Medicine, or NASEM 2021 report on implementing high quality primary care proposed a U.S. national scorecard on the health of primary care to track the implementation of the NASEM Committee's recommendations for high-quality primary care across the country. And in response to that report, the Milbank Memorial Fund developed a national primary care scorecard and has since released 3 annual scorecard reports. And there are also state-level scorecards that have been developed in Massachusetts and New York and Virginia. And in California, the Primary Care Investment Coordinating Group of California, which is convened or was convened by the California Healthcare Foundation, recommended in 2022 that California track progress toward high-quality primary care by developing a state scorecard. And the idea has received broad support from stakeholders, and in 2024, CHCF also funded efforts to explore a primary care scorecard development. And this led HCI to step forward to lead this statewide initiative, which is now, at least working title, is the HCI Health of Primary Care in California Snapshot. So if we could go to the next slide. So again, you may recognize this. This is the vision for primary care delivery that was used by OCA and the Investment and Payment Work Group to guide our decisions about the specific types of care that should be included in OCA's primary care spending measurement and definition. And wanted to highlight this vision again, as we will continue to refer to it to align and focus the primary care snapshot and develop resources for stakeholders that promote and measure progress towards high quality advanced primary care. So we'll be using this vision again to inform and kind of guide our snapshot development. So if we could go to the next slide. So the purpose of this snapshot is several-fold. So first, it will create a shared understanding of the health of California's primary care sector, both statewide and for geographic regions within the state. Second, it will track progress towards equitable, high-quality, and sustainable primary care for all Californians. Third, we'll monitor California's overall performance on supporting key elements of the health of primary care in California, such as primary care investment and primary care quality measures. And finally, it will help identify gaps and challenges to inform action on access, workforce, investment, and other key areas. So in short, the primary care snapshot will report on system-level performance across multiple domains to document the current status of primary care, monitor change over time, and motivate action to improve statewide performance and work towards achieving that vision for primary care in California. And I'll just note briefly, the 2 figures on this slide are taken from the Milbank National Primary Care Scorecard. And the Milbank Scorecard includes 4 domains, and we've shown 2 domain examples here, financing at the top and access at the bottom. And the other 2 domains in the Milbank Scorecard are training and research. If we could go to the next slide. So our planned approach to the primary care snapshot is not to collect new data, but to analyze and compile existing data from across HCI and external sources to create a comprehensive picture of primary care in California, both statewide and, when possible, at a regional level. We will look at primary care data across HCI, sibling state departments, and other sources to incorporate into the snapshot. And we plan to focus on 5 key domains, and those are investment, workforce, access, quality, and equity. And these domains align with the priorities identified in the NASEM report and the domains in other state scorecards. And they also nicely reflect the expertise of HCI in primary care. And we propose on using a phased approach to develop the snapshot, so beginning with a static report on the key domains and then adding interactive features over time. And we'll review this approach in more detail in the coming slides. And the ultimate goal is to both have a static report that's, fairly short, easily digestible, and then have an interactive dashboard where data are updated on an annual basis and folks can filter and sort to get into more detail. And then in terms of the audiences for the snapshot, our current thinking is that the primary audiences will be our engaged stakeholders, And although the general public is not the primary audience for the snapshot, we think there will be opportunities to develop communication and content that increases public awareness about the challenges facing the primary care sector in California. And if we could go to the next slide, we'll just show an example of some of the other states. So on this side, this is an example of the primary care dashboard in Massachusetts. And they have updated this dashboard yearly since 2023. And as we plan to, they do have both an interactive dashboard and a static report. And we had the opportunity to learn from the Massachusetts team, and they presented at our first primary care snapshot stakeholder work group last November, or just a few months ago. And we're excited to continue to learn from the Massachusetts team in terms of how they developed their dashboard and how they are using it currently. And then on the next slide, this is an example from Virginia. So the Virginia Primary Care Scorecard has, again, both interactive dashboards and static reports. And they also include lots of interesting geographic detail from across the state. And we hope to incorporate some similar geographic detail where feasible. And now I'll pass it on to Debbie to describe what we're working on.
Thanks, Margareta, and good afternoon. Feel free to stand up and stretch if you need to at this hour. We're ahead of schedule, so that's good. So as Margareta mentioned, I will dive into some more detail about the Primary Care Snapshot Initiative, starting with the project team. So the snapshot is a collaborative HCI effort across our Office of Health Information, which runs the Healthcare Payments Data Program, or HPD, the Office of Workforce Development, the Office of Healthcare Affordability, and the Office of the Patient Advocate. So through this collaboration, we can leverage expertise in data, workforce, spending, equity, and quality across all the HCI offices. And we are also pleased to have support for the primary care snapshot from Friedman Healthcare and from Dr. Diane Rittenhouse of Mathematica. And lastly, we'll be collaborating with the California Healthcare Foundation, or CHCF, on communications to support dissemination of the results of the primary care snapshot. We can go to the next slide, and where we'll see that as a collaborative HCI project, the Primary Care Snapshot Initiative will leverage HCI's existing reporting structures related to primary care, including those that are listed here on the slide. So starting on the left, which is familiar to all of you, the purpose of OCA's primary care reporting is to report on plan level performance toward the annual improvement and statewide primary care investment benchmarks in order to increase investment in primary care. The Office of Health Workforce Development reports on health workforce employment and education data trends, including for the primary care workforce. For example, they report on new and expanded primary care residency slots across California that are supported by the HCI Song Brown Healthcare Workforce Training Program. They're also working on developing reporting on primary care workforce supply and demand to address shortages and maldistribution and to guide workforce-related policy. The Healthcare Payments Data Program, or HPD, is managed by HCI's Office of Health Information. And HPD data is used to report on primary care metrics such as primary care clinic utilization and other related metrics like avoidable emergency department visits. The Office of the Patient Advocate, which is recently incorporated into HCI, releases quality and patient experience reports on health plans and medical groups, including for primary care services. So while each of these offices conducts distinct primary care reporting, elements of the reporting across all of the offices will be incorporated into the primary care snapshot. And as Margareta noted earlier, the snapshot will unify primary care data across HCI offices and also across sibling state departments and other sources through a concise set of primary care metrics that provide an overview of the health of primary care in California. Go to the next slide, which outlines the proposed key deliverables and timeline that illustrates our phased approach to the primary care snapshot development and how the deliverables build on each other over time. So we'll be starting with the HCI brief on the health of primary care in California, which we plan to release very soon, just later this month. And the brief will announce the snapshot and introduce HCI's approach to the static and interactive snapshot development and stakeholder engagement. It will also provide an overview of the current state of primary care in California and identify those 5 domains for future snapshots. This coming fall, we plan to release the Healthcare Primary Care in California snapshot as a static report. And this report will include indicators under each domain to be incorporated into the full interactive snapshot later on, and also give an update on the timeline for development and release of that full interactive snapshot. And then in 2027, we are planning to release the interactive snapshot, which will also include a static report and will feature key indicators in each domain. And from 2028 onwards, we will update the full snapshot, both the static and the interactive versions, yearly. And I will note, as Margareta alluded to, the names of and the content within these deliverables are tentative and may be revised, but these are our working titles right now. On the next slide, I want to talk about a key early step in snapshot development, which has been to compile an inventory of primary care metrics or indicators. And the goal of this inventory is to identify high-value indicators for each of the 5 domains from California and across the nation that can support the development of indicators to include in the primary care snapshot in 2026 and beyond, and to prompt discussion of current and future indicators from within and outside of HCI to incorporate into the snapshot. So after curating an inventory of over 100 California and other state and national indicators, we're now evaluating these indicators for inclusion in the snapshot. And our initial set of proposed criteria for evaluation are listed here. And those evaluation criteria are that the indicator should be of interest to and actionable for California stakeholders. The indicator should be supported by existing accessible California data sources or national data sources with California-specific data that can be tracked over time. The indicator should directly measure the strength of the primary care sector, and the indicator should track change in the primary care sector aligned with the 5 key domains. We plan for stakeholders, and especially the primary care snapshot work group, which I'll talk more about in a moment, to provide additional input to refine these criteria for evaluating snapshot indicators. On the next slide, we can see that stakeholder engagement is a key element of this project. Our stakeholder engagement approach has several components guided by the principles of engaging a diverse set of stakeholders and soliciting their input to create a relevant and actionable slate of primary care indicators. So first, we formed a new stakeholder work group to provide regular guidance on snapshot development. The work group is designed to be a smaller group with primary care expertise to give us detailed input as we design and develop the snapshot. We identified 6 stakeholder categories to engage for this work group, which are shown on the slide: providers, health systems, health plans, purchasers, consumer and policy advocates, and academic and subject matter experts. The primary care snapshot work group had its first meeting in November, and we'll share more about the work group in upcoming slides. The second arm of our stakeholder engagement approach is to leverage existing HCI stakeholder bodies, including this committee, the Affordability Board, the OCA Investment and Payment Work Group, the Health Workforce Education and Training Council, and the Healthcare Payments Data Program Advisory Committee. We'll also seek input from sibling state departments like CalPERS, Covered California, the Department of Healthcare Services, and the Department of Managed Healthcare. And the goal with these engagements is to gather high-level consultative input. And then third, we'll conduct some individual key informant interviews with stakeholders as needed to elicit candid feedback on the domains, indicators, preferences, and trade-offs, and to fill in any gaps and ensure that our stakeholder representation is diverse across California's primary care landscape. So thus far, in addition to our first 2 snapshot workgroup meetings, we've introduced the snapshot to the Affordability Board and to OCA's Investment and Payment Work Group. And stakeholders there have expressed interest in indicators that measure patient-provider relationships, like continuity of care and of coverage, performance across markets and within markets, geographic and population variation, performance for underserved populations, and the practicing primary care workforce, including the pipeline through and beyond residency. Some other topics that stakeholders have highlighted include reimbursement of primary care providers relative to specialists, barriers to primary care investment and delivery, flow of funds within provider organizations to primary care, and tracking relationships between primary care policy initiatives and performance in each of the domains. So we will be closely monitoring and evaluating all the stakeholder feedback for incorporation into the primary care snapshot. And while we may not be able to answer all stakeholder interests via the snapshot, we will maintain a transparent process to explain why some indicators or topics may not be included. And for example, we may be unable to implement certain indicators or topics into the snapshot due to limited data availability. We can go to the next slide. So a little bit more on the work group. The purpose of the new primary care snapshot work group is to provide primary care policy, data, and clinical expertise to inform the development and implementation of the snapshot. The objectives of the work group include to offer a transparent public forum to understand stakeholders' priorities for the snapshot, to engender thoughtful, comprehensive, and balanced stakeholder engagement to ensure strong buy-in and smooth implementation, and to provide expert technical input on the availability and feasibility of primary care indicators to include in the snapshot. So specific activities of the work group are listed here, and I'll highlight just one of them, which is informing the development of primary care indicators for the snapshot that will promote equitable, high quality, and cost-efficient care. We began our discussion of indicators with the work group earlier today, and I know several of you joined for at least part of the meeting, so thank you for joining. And those conversations will continue through 2026. On the next slide, so this is our the 17 members of our work group, and as you can see, we've put together a group with extensive expertise across a range of stakeholder perspectives. So we're really excited to have these individuals and organizations on board to support development of the snapshot. And the link to the Primary Care Snapshot Workgroup webpage is included at the bottom of the slide if you're interested in learning more about it or attending upcoming meetings. Next slide. So our first deliverable for the Primary Care Snapshot will be the HCI brief on the health of primary care in California, which is scheduled for publication on the HCI website later this month. And the brief will include an overview of the purpose of the Primary Care Snapshot Initiative, a summary of the current state of primary care in California, including baseline and contextual statistics from existing reporting that we identified during our indicator inventory development process, and a vision for the snapshot describing our phased approach and timeline for interactive snapshot development. And alongside publication, we plan to distribute the brief via the HCI and OCA listservs and to announce it on HCI's social media channels. So look out for that very soon. And our final slide, I will wrap us up with this timeline, which is an overview of the primary care snapshot development since we launched the project in July of last year and through this coming year. So in gray is our completed progress so far, and the green dot represents where we are now. Since we launched the project, we've initiated our stakeholder engagement, launched our primary care snapshot work group, and begun reviewing our inventory of possible primary care indicators. And this year, following the release of the snapshot brief, later this month, we'll begin development of primary care indicators for inclusion in the 2026 snapshot static report with input from the snapshot work group and other stakeholders. And we anticipate the release of the 2026 static report, which is our second snapshot deliverable, in fall of 2026. And after that, we'll begin developing additional indicators for inclusion in the 2027 interactive snapshot and report. So thank you for your attention. We appreciate the opportunity to present this overview of the Primary Care Snapshot Initiative to you today, and very much welcome any questions or feedback that you may have.
All right, we'll turn to the committee. I've got Sumana and then David.
Thank you so much. This is super vital work and I'm really excited about it. Just some comments because it's a whole world of critical information to gather to keep primary care sustainable. And you all recognize the stakes. So the workforce issues, you have the data already, just looking at the ages of physicians in primary care and what's happening. The replacement issues are indeed dire, and more so because APPs come out and are not able to be trained by the physicians out here. There is not an environment for supporting the training after the training, and I just want to highlight that as a particular need for sustainability and growth in primary care, even if we count on non-physicians to provide a lot of that care. I wanted to have us look at, you know, the Steve Green, the rather than the CAP surveys, better ways of capturing the relationship and satisfaction that patients have, and could we consider as part of that snapshot, you know, clinician satisfaction within the system. Access, I'm seeing these punitive measures from payers that are really troubling to me in a tiny little group like mine. We have differentials on copays. If that patient sees a PA in my practice, there's a $35, there's a $45 copay, and if they see me, there's a $15 copay, and this is, Katie knows about this, it's the teachers union has set this up. That is just unacceptable because I have no way in a small team to ensure that, and yet I always know when my PA has seen a patient. We have to push payers to not respond in these ways, and we have to define access in more reasonable ways than we are doing right now. And again, caution about quality because we're going to lose people if we keep pushing these very narrow definitions of quality and report carding clinicians on that. And that's probably enough other than to say I heard part of that and we'll try to listen to those because they're so important and appreciated. Specifically, I'll call out Dr. Kevin Grumbach's comments on, you know, this snapshot being not just a snapshot, but having some depth to it, so we can really look at it over time to enhance California's care. Thank you.
Thank you. I've got David, Stephen, Amanda, Mike, I see your hand raised online, and then Joan.
Yeah, thank you for this. It's very, very important, and I'm very impressed by the rigor you're applying to this. One comment I wanted to make is that I heard you already talk about looking at regional differences, and I'm sure you're going to focus on urban versus rural and so on. But one factor I think is really important to keep in mind is that there's at least 3 categories of types of primary care in most markets that I'm aware of. You've got the primary care that's employed by large systems, like in Sacramento, it would be Sutter or Dignity or Kaiser. Then you've got your primary care that's a part of independent physician-owned practices. And then you've got primary care that's in federally qualified health centers, FQHCs that primarily serve the Medi-Cal populations and some Medicare and commercial. And the economic challenges and the rates that are commanded from health plans for these different entities and the amount of federal support they get, they're radically different. And so I think it's always, if you try to look at primary care and blend all these together, it can be very misleading. I'd strongly urge you to look differently at system employed differently from independent physician-owned to federally qualified health centers. Very, very different dynamics and economics.
Thank you. Stephen?
Yeah, really important work, and I congratulate OCA and all the groups I know that are working with you on this, and just to underscore what Samana and David has said, adding maybe some early comments in addition to the breakouts that David has indicated. to look at the data when it's ready to be reported by the value-based payment models by payment source. And by the FQHCs, also would be another breakout in that regard. I mean, our expectation, I guess, would be that those primary care organizations, providers that are further along in value-based payment, because we have a whole work group on that, would indeed be the ones that are doing better in primary care, given the incentives within those kinds of payment models. But that's an empirical question. That's part of the learning and making sure that, we link these dots in terms of OCA's overall, initiatives that you have. That would be one suggestion. The other thing as you choose the measures is to be able to have enough sensitivity or nuance in them, perhaps, at least over time, to look at so-called improvements in primary care. In other words, if our target is to increase percent primary care spend from the current 5 to 15% over time, right? Where is that money going? Is it going down to the primary care clinicians to improve patient care? Is the money going to be used to raise salaries? Is it going to be used for more IT infrastructure or for AI implementation or for care coordination? So to be able to track that. And a related suggestion is that some of the measures may be more qualitative or almost proximate. So we'd like to see maybe over time an increase, I know the Office of Patient Advocate, right? The increase in the percentage of patients with diabetes that their blood pressure and sugar levels are in control. But that doesn't occur overnight. Some groups have been working on this for years, right? Sometimes it's very difficult to change clinical workflows and patients and compliance, adherence, et cetera, et cetera. So maybe instead look at things like workforce retention, stability. There's less turnover in these practices. Or maybe, for example, there are fewer missed appointments. Data can be collected on that. So these are more proximate measures, and not to say, well, this is kind of a failure because after 2 years, no more patients are under control for diabetes, so this primary care initiative isn't working. And the other suggestion is maybe after 2, 3, 4 years, my understanding of the data available is some of it's just, as you say, Margareta and Debbie, it's just not going to be available. You have to go with what you have. So consider the need for some primary data collection, at least here in the state, after maybe 2 or 3 years to fill in the gaps. And people can work with you on that, if one can secure funding from CHCF to fill in some of the data that we just won't have.
Thank you, Mike, and then Joan.
Thanks, Mike O'Day with Children Now. Appreciate the presentation, and I was curious if, I know that there are significant data limitations and it doesn't always work as cleanly as we'd like, but were you able to identify any indicators or do any analyses of primary care investment by population? Specifically, I'm thinking about how much of the primary care dollars go towards children and youth populations versus older populations, and so curious if you can share anything there. Thanks.
Thank you, Mike. Good question. So for OCA's primary care spending data collection, we are not, breaking out spending by different age groups. In some of the other data that we are considering for the snapshot, we should be able to break out the data by age groups. So there may be primary care indicators that we report on via the healthcare payments database that can be broken out by different age groups and potentially other population stratifications. So I think that's a really good flag for us to consider both, other stratifications and to make sure age is included in that stratification where possible.
Thank you. Joan, then Janice.
Adding a couple more to that stratification discussion. One, it's been very helpful within the HPD public snapshots to be able to group by major payer type, Medicare, commercial, Medi-Cal, and even within that, there have been some places where the HPD very helpfully has done Medi-Cal versus all other for where we think that the Medicare population probably looks more like the commercial population. So thinking through where will different payers impact, where will managed care versus fee-for-service impact, and then also where is Kaiser a completely different entity, and that may be something where including Kaiser with the rest of commercial could just really warp the numbers. And so where is it appropriate to separate Kaiser out?
Yes, thank you for those flags, Joan. And yeah, those have come up in our discussion, so I think we will look at those for each indicator as available.
Okay, I've got Janice, Amanda, and then Michael.
It's just a couple things just to add on, having that information on the differences between different entities like private hospitals and FQHCs, also county departments of public health, and how that all, the differences between those entities and how they provide care and the quality and access to care, I think is important. But for the workforce piece on this snapshot, are you planning on looking at that? I'm thinking from like the nursing perspective, so from start to finish, whether individuals have access to training, to education, how access is impacted by being place bound, so where they live, do they have access to that education? And then I guess what's the pipeline? Are there a number of current nurses or other healthcare professionals that are planning on retiring over the next 2 or 5 years? That's going to bring a big gap in the healthcare sector. Those are kinds of questions I had on what you're looking at providing in this report on workforce.
I think those are all good things for us to consider. I think we would need to go back to our colleagues in the workforce office. I don't know, Debbie, if there's anything else you want to add.
I'll just add, Janice, we're very interested in the workforce pieces, and so we do separately, again, as part of HCI, have a research data center specifically looking at workforce, and so we do look at things like retirement age, and so we are currently publishing that workforce data.
Amanda?
Thank you. Just want to express gratitude for the work that's been done on this. Really excited to see the advisory group, getting started, and the data that we've been able to get, the snapshot, the brief, and we know that primary care access and improving access to primary care is good for consumers, right? It's better to be able to manage chronic conditions rather than end up in the emergency room, and it's good for the mission that we're all here for, right? To reduce the costs. It's much more cost effective to be able to deal with healthcare conditions as early as possible, to have a regular source of care, to have all of that. And so, really grateful for this work, and excited to see what comes out. And I think to that end, I would be curious, about additional opportunities to get this information out with regard to dissemination of the brief. I think as we talk to legislators, for instance, I think there's a lot of there isn't a great understanding of where dollars are spent in our healthcare system. I think a lot of times when people hear about the work that OCA is doing, there's always an assumption that it's going to be less. It's going to mean less. And this is an instance where actually I think we can and want to see investment in primary care, and actually more, and where there's real opportunities for better patient experience and and improve outcomes and lower costs, right? It's like, this, the unicorn, right? So So, just would really encourage, encourage HK to think about how to maybe get this information out more broadly and like brag a little bit about the work that OCA is doing on primary care. I think it's really important work.
We will definitely think about our communication strategy, and we hope all of you will help us brag about it and get it out there.
Done.
Michael.
Yeah, this is very cool, and I'm very glad to see you have a couple of pediatricians on the work group. Thank you. Just a thought, if I didn't hear it, but if it's possible to parse it out also by payment methodology, it would be interesting to see capitated versus fee-for-service models. Empirically, you would think with capitation, there's more money going toward primary care, but I don't know if that's true or not, but that might be an interesting thing to look at.
Any further discussion? Thank you. All right, well, that takes us to public comment on this agenda item, and also because this is the last item on the agenda, this is also the general public comment period. So please step to the podium or raise your hand if you're attending virtually. Seeing no one at the podium, looking virtually, seeing no hands right now, we'll give it just a moment. All right, I believe that concludes public comment on both this agenda item and for the meeting, the next advisory committee meeting on April 15th, 2026. Yes, please, Stephen.
One comment building on David, I think I just saw this health affairs piece you mentioned, I think. I'll just read, this will take 10 seconds, right? Conclusion, just came out in health affairs, update on healthcare spending in the U.S. We're now at 18%. And it continues to outpace growth in the GDP. Strong overall healthcare spending in 23-24 was due to growth in personal healthcare spending, which averaged 8.9% and represented the highest rate of growth for 2 consecutive years in more than 3 decades. 2 consecutive years for more than 3 decades. The strong growth in personal healthcare over the course of these 2 years was driven primarily by non-price factors, such as the use and intensity of services, particularly for hospital care, physician and clinical services, and retail prescription drugs. I guess that's why we're here.
Absolutely. Stephen, thanks for reading that. Vishal and I got it by email while we were meeting after David mentioned it. And yes, it's why we're here. So thank you all for your collaboration. Meeting is adjourned.